But in India, I assume that they are still doing dissections in anatomy classes, which means that you could essentially televise a dissection session with a good teacher who can dissect properly and show the structures, and that can become a lecture worldwide for anatomy. So that's what he was talking about 20 years ago. But look at what we are doing right now. This is very similar to what he kind of envisioned at that time. Hi, Amish. Did you get my presentation?
Yes, sir. Yes, sir. Got it on time. Thank you, sir.
Okay. So what I'll do is I will try to share it from my end.
Yes, sir.
And if it works, great. If it doesn't work, you can upload it.
Yes, sir.
While I was preparing this talk, I went in about 20 directions. And I said, and each direction was like taking me 20, 30, 100 kilometers. And I learned a lot, but the problem was I said, wait a minute, I have only 30 minutes. There is no way I can cover this much. But hey, you know what? There's a story I tell my fellows and residents. The best learning I did was by actually teaching. When I was an intern in JIPMER, I asked one of my colleagues, he's a senior to me. I think he's still there. I don't know if he's retired. So I asked him to teach me about EKG. So he said, oh, sure, no problem. Why don't you come at this time to this particular unit and I'll teach you. We'll do something. So I was eager. He's going to teach me. I'm going to sit down one-on-one. And I went there. And he had 8 medical students, I think 3rd year or 4th year, first clinical year or second clinical year. And they had just finished their session with him. And he said, okay, he's going to teach you EKG. I said, Bala, I came to you so that you could teach me EKG. He said, no. You are going to teach them EKG. That's the way you're going to learn. So, hi, Arun. Okay, whoever is a father here, happy Father's Day. Today is Happy Father's Day in US.
It's same over here as well.
I think all are.
All are.
Any fathers? Mother's Day already finished in May.
That's every day, Shekhar.
Don't know about that.
It's Women's Day. Every day is Women's Day.
I tried.
Every day is Women's Day.
I believe in women's equality as well as men's equality. So,
Uma ma'am, I tried.
Nice to see you, Indra.
How are you? Nice to see you. You okay?
Yeah, good. Yeah.
Excellent, madam.
Yeah.
So I didn't send you, Amish, because I'm a last-minute person. In the sense, whatever I do 2 days before, I find it's horrible, and how can I speak this? So I keep changing and changing. I hope it works.
You know, the best thing that has happened to us and the worst thing that has happened to us is being able to create PowerPoint presentation. So I remember a time when we had to make presentations at meetings, research presentations. You had to get your slides made, like those slides that you put it in the slot, like two weeks ahead of time. Yeah, they won't make it if you...
I have done that. I've done that, and then they came the transparencies. I've done
Yeah.
the presentation
Transparencies, overhead
transparencies
transparencies, and then
OHP.
yeah, and then this the computer stuff came, and at that time the computer stuff you could only print it out. You could not actually project it. They didn't have projectors those
Yes.
days. Then the projection and everything came. And so now the thing is, a lot of times I'm preparing my talk while I'm actually traveling. No, it's actually, that's not correct. So whenever I give talks in India, for example, I've been thinking about the talk a lot, and I've been collecting materials to create the talk. So what happens is, in my mind, the talk is already being prepared in my mind. It is just putting it in a format that makes sense, kind of in the PowerPoint. But I already kind of, I've been thinking about it. I know what I want to say. Suddenly, some idea will come. I'll just type it into that format. But if you look at my computer, every talk that I give, I have all the references that I use for that particular talk in that particular folder. So I can, when I'm in the plane, I can look at it and say, okay, this is what I want to say. Hello, Chidambaram Lakshmanan.
Dr.
I don't
Baswaraj,
think,
thank you for joining.
I don't think we have met before.
He's a junior consultant, Shekhar. He will be presenting the cases. Apollo Children's.
Apollo Children's, okay. You're with you're with the best, some of the best.
Yeah.
The rest of them are sitting around her.
Good evening,
Dr. Basavaraja.
Good evening, sir.
Good evening, sir.
How are you, sir?
I'm very good.
Hi, Harun. Good
Happy
evening. Good
Happy
evening.
Father's Day.
Hi.
Yeah. Hi, Mahesh. Good evening.
Hi, Basaraj.
Madam, good evening. Good evening.
Hi, Arun. Hi, Paramanand. Hi,
Paramanand, good
Indira.
evening.
Hi, Mahesh.
Indira, madam.
Hi, Amish. Lakshmi.
Nice seeing you, Baswaraj ji.
And
You
of
must be
course,
like
Madam.
totally busy all the time.
Madam Umali. To the viewers, to all the viewers on this platform, let me tell you one thing. Madam Umali recently or last year gave one of the best talks I heard was an applied physiology of kidney. If you get an archive, it's an archive talk on the DIP. It's one of the best because I have re-looked it at least on 3 occasions. Every time I find at least 2-3 new points. It's a wonder, one of the best talks. It's an applied physiology on of the kidney. I'm sure Baswaraj will agree to that, right, Baswaraj?
Yeah, we were witness to
Live
that,
on
Mahesh. We are witness
Absolutely wonderful talk.
And one more talk, madam gave in an MBCon, I think. Cross talk of a kidney and lung. If you
Yes.
So there are actually
2018,
like that.
Yes.
There are hundreds like that, but I mean, they are really wonderful kind of talks.
I'm sure she'll enlighten us much more today. Like ever, we'll always be a student and we'll keep on listening and learning.
Always.
Yeah. I think you're making me nervous by this great expectations.
No.
So this may not really be that.
So Amish,
I once read a statement by Sachin Tendulkar also that even after 100 tests, when he go out to bat, he feel nervous.
You feel
absolutely.
No, very well said, Arun. Yeah.
I tell my fellows that when I go into the ICU on call, I am as nervous as I was when I was a fellow. It's
okay. Lakshmi, it is 8:30. Can we start?
I have a suggestion, Sheikh.
Yes.
Usually when we moderate something, we kind of introduce the speaker and, and then at the end, maybe make comments, but I don't think we should do that. Let us both kind of present and then just go straight into questions. Because I don't think, my own personal view is I think we should answer other people's questions rather than my commenting on Uma's talk or she commenting on my talk.
No, very well point. Sir, we are just going to have 2 talks and straight question answer.
I agree with that.
Lakshmi is going to introduce Dr. Uma Ali and Madam is going to introduce you. Okay, and then we straight go to talk and Dr. Baswaraj will just say a few words to begin with.
Yeah.
Okay,
We can even dispense with the introduction. I don't think any of us need any introduction. So
Yes, sir.
Unless nobody knows me about me. So
Yes, sir.
No,
That's
everybody
fair enough,
knows
sir.
I think that is not possible after so many years in every intensive care meeting.
Yes.
I think everyone knows you very well.
Yeah.
Sir, all intensivist in India knows you.
Yeah, and sir, just to it's a part of tradition, so it's we have to have small words. We won't stress too much. We won't stress too much. So Lakshmi, to start, please.
Go ahead.
Good evening, everyone. A warm welcome back to the second day of CME on Back to Basics by the Mumbai Critical Care Chapter. Today's talk is special because it's full of teachers, my teachers and their teachers. It is something which is very, something we're all looking forward to. I would invite Dr. Basvaraj for a few short comments, after which we begin the talk.
Thank you, Dr. Lakshmi Shobhawat, madam. Thanks to our Mumbai critical care team led by Dr. Parmanand Anandkar, Dr. Meena Sheikh, Dr. Amish Oraji, and our intensive care chairperson-elect of National, Dr. Mahesh Moite, and Secretary of our IAP Intensive Care Chapter, Dr. Harun Bansalji, and teachers of teachers, Professor Humali Madam, and Professor Shekhar Venkatraman, and all the other dignitaries and other faculties of it today, Dr. Indra Jay Kumar, Dr. Kanav Anand. So really, the scientific program, yesterday I missed it. It was an excellent thing. What is really required for an intensivist today also, it is going to be very pleasurable to listen to the Professor Uma Ali Madam. Always, once you listen, always love to listen to Madam and Dr. Indra Jay Kumar and Kanav Anand. Of course, the comments, even though Professor Shekhar Venkatraman sir says, I'm not going to comment it, will not leave you, sir. We are eagerly waiting for your comments. So with these few words, I don't want to take much time. Looking forward for a good interactive discussion of our scientific program. Over to Dr. Lakshmi Shobhawat. Thank you very much for inviting me.
Thank you, sir. Dr. Arun Bansal, our intensive care Central IAP Secretary, sir, would you please give us a few quick words?
Yeah, good evening, everybody. And it's again one of a very good initiative and a good platform to learn something from the stalwarts. It's a really a humbling experience to listening to Shekhar, Dr. Umali, and our friend Indira and Karnav. They are all there. So we have a great lineup of speakers. And Baswaraji, Mahesh, and all others are here. So it's a great evening. Hopefully, we'll have some good academics. And congratulations to Amish and Parmanand and Sheikh for organizing this. So thank you so much.
So, good evening, everyone. It is a great pleasure that I Dr. Mahalish actually doesn't need any introduction. She is the senior pediatric intensivist, pediatric nephrologist. She's been practicing for many years, and she is associated with the SRCC Children's Hospital, and she has been a teacher to all the intensivists that I know. Everybody in Mumbai has been trained by her, is what I feel, and it's only because of her teachings that we are where we are. Welcome, Dr. Umali. Madam, I would request you to introduce the first speaker, Dr. Shekhar Venkatraman.
Thank you, Lakshmi, for the introduction, but I think all my students have gone far beyond me now. And I'm very pleased to introduce Dr. Shekhar Venkatraman, who, as we said, does not need introduction to any intensivist in India, as he's been part of our intensive care group ever since it began. He's professor and head of critical care medicine at University of Pittsburgh. And he's a brilliant teacher who blends physiology very well with evidence. So once you've heard his talk, it's something that remains with you for a long time. Welcome, Shekhar, with your talk.
Oh, thank you very much. Can I share the screen? Can you let me share the screen?
Bhavik?
Yeah, so you can share the screen. You can share the screen.
Okay. Slideshow, share. Can everybody see the slides?
Yes, sir.
Yeah. That was a picture when I still had a little bit of hair. Okay. I mean, this talk in hyponatremia, I was telling everybody that I was going in 20 different directions, going into some details that I didn't know before. It was fascinating for me to read that. But then I realized that it was becoming too complicated. So this talk for the next 20 minutes or 30 minutes is going to be fairly simple and straightforward. So if I miss something, and if somebody thinks of a particular problem, please point it out so that I can correct it for the next time I give this talk on hyponatremia. So roughly, this is what I'm going to talk about. It may not be in the same sequence. Some definition, some normal physiology of how the kidneys handle sodium and water, causes of hyponatremia, classification of hyponatremia, a clinical approach to hyponatremia diagnosis, as well as therapy. I won't focus too much on the therapy because the therapy depends on the particular cause of the hyponatremia, because then therapy becomes too complicated. So everybody should know what the treatment of one particular cause of hyponatremia is. So let's first start with some basic physiology about composition of body fluids, because water is present in the body fluids and sodium is present in the body fluids. So if you look at the body compartments, on the left-hand side are two pictures. In the top picture is sort of a rough idea of the spaces. Intracellular space is about 2/3. Extracellular space is about 1/3, of which 1/3 is vascular space and 2/3 is interstitial space. You have fluid intake and fluid output. Water actually freely moves between these spaces due to osmotic concentration difference between the two spaces. So the main barrier between intravascular space and the interstitial space is actually the capillary endothelium. And between the interstitial space and the intercellular space is the cell membrane. Water moves freely. Sodium is the major determinant of extracellular fluid osmolality. The sodium concentration outside the cell is higher than inside the cell because of active transport of sodium across the cell. The concentration of potassium inside the cell is much higher than the concentration of potassium in the extracellular fluid space due to active transport. If you look at the total body weight, 60% of an adult or an older child is total body water. The other tissues contribute to 40%. If you look at percentage of intracellular fluid, it's about 2/3 of the total body water, and extracellular fluid is 1/3, of which interstitial fluid is again about 2/3 to 3/4, and intravascular fluid is about 1/4 to 1/3. But this 0.6 or 60% is not entirely correct in pediatric population. If you take the newborn's total body water is about 80%. So if you're going to do some calculations for using total body water for the newborn, you may need to use a slightly higher number than 0.6. So in pediatrics, we generally use 0.6 as the correction factor across all age groups, but I think we need to modify that for the younger patients. So let's come to the physiology of sodium balance. So this is the distribution of sodium in the human body. This is published in 2018. These are the percentages. So you can see that the sodium concentration, the amount of sodium in plasma is only 10% of the total body sodium, but it actually reflects the extracellular fluid concentration. Interstitial fluid, on the other hand, which is 75% of the extracellular fluid space, has 30% of the sodium in it. We don't, initially when we think about body compartments, we don't think of sodium presence in the tissues, but the tissues do have sodium, bone especially, and hard and soft tissues. So this is a very busy slide, but I will try to go through step by step. You have all the parts of the kidney represented here: the proximal tubule, the later part of the proximal tubule, the ascending limb of the loop of Henle here. Can you see my arrow? Can you see my pointer? The distal convoluted tubule.
Yes, sir, it's visible.
The cortical collecting duct. And then the last slide is the action of ADH on the collecting duct. There's a spelling mistake here. See, I did this late last night. That's why I didn't make any corrections. You see what happens when you use PowerPoint at the last minute? So in the proximal tubule, most of the sodium is actually reabsorbed in the proximal tubule, but it requires energy. It is done through sodium-potassium ATPase. Now, this is the lumen of the kidney, and this is the blood part. So sodium goes across, and actually it exchanges for hydrogen in the proximal tubule. And when sodium comes in, chloride also comes in at the same time, and water also comes in at the same time. This is active transport. There's also passive transport in between the cells, but that doesn't constitute a large portion of the sodium transfer from the lumen into the blood. In the later part of the proximal tubule, again, sodium is exchanged for hydrogen, but also other solutes, other anions are also exchanged in place of hydrogen. I won't go into the details of this because I think the details are not that important for this particular talk. I'm sure Uma's talk on renal physiology covers this in much more detail. When you come to the loop of Henle, there is something else happening. That is, it becomes impermeable to certain things. It is permeable to certain things due to active transport. So it is impermeable to water. So the water actually the sodium concentration gets diluted there. The distal convoluted tubule also has differential permeability to solutes. And I will not talk about the details because that's not the intent of this talk. And then you have the cortical collecting duct where there is a lot of multiplier concentration happening of the osmolality of the urine. The action of ADH on collecting duct is to reabsorb water. When ADH is present, it actually will make the collecting duct reabsorb water. When ADH is not present, water will not be reabsorbed. So, summarizing this, sodium is actually freely filtered. It's actually quite interesting that 99% of the filtered sodium is actually reabsorbed in the proximal tubule. Normal fraction excretion is about 1%. Reabsorption is 65% along the proximal tubule, 25% along the loop of Henle, 6% along the distal convoluted tubule, and 3% across the collecting duct. And energy is required at the basolateral membrane for absorption of sodium. This is proximal tubule. Water, but not solute, is removed from the thin limb of Henle loop. It increases luminal concentration as the fluid approaches the tip. This is that countercurrent multiplier that I was talking about. But when it goes across the thick ascending limb, it is the sodium, but not the water, that is reabsorbed. It is impermeable to water in the ascending limb, but it's impermeable to sodium in the descending limb. So this dilutes the tubular fluid along the thick ascending limb. Along the distal tubule, it is sodium but not water that is reabsorbed. And sodium is reabsorbed along the collecting tubule and collecting duct as well. In the distal tubule, instead of proton, it's actually potassium that is exchanged with sodium. And that is why if you have excess sodium coming to the distal tubule, you will actually lose a lot of potassium as well when sodium is reabsorbed. And aldosterone is very actively involved in the distal tubular reabsorption of sodium. So the renal sodium homeostasis actually responds to what is called an effective arterial blood volume. It's a virtual volume that represents the fullness of the arterial tree. That seems to be a signal for renal sodium reabsorption. And that concept is actually quite important in disease states, as I will show a couple of slides later. Sodium reabsorption also responds to arterial pressure, a phenomenon called pressure natriuresis. When the pressure goes up, it actually will promote sodium excretion. Sodium absorption along the proximal tubule is also regulated by peritubular protein concentration and other physical factors such as filtration rate, because it increases the oncotic pressure in the lumen. This link between filtration and reabsorption is called the glomerular tubular balance. And if you have disease states of the glomerulus, then this gets affected. If you have inflammation of the glomerulus, then this particular balance gets affected, and it will affect sodium balance, it will affect water balance, it will affect protein balance as well. So it's also stimulated by hormones. So circulating angiotensin II will promote renin formation, which will then control the EABV, or blood volume contraction, or the sodium absorption along the second half of the distal convoluted tubule is aldosterone sensitive. Aldosterone secretion is regulated by angiotensin II and by serum potassium. So when serum potassium goes up, aldosterone secretion will actually increase, trying to excrete potassium and reabsorb sodium. So if you block this with spironolactone, for example, what you get is actually hyperkalemia. That is, potassium excretion is decreased, and sodium reabsorption is also decreased. So natriuretic peptides also promote sodium excretion in the kidneys. The natriuretic peptide, we know, are stimulated by, they're basically produced in the heart and in the brain, and they're stimulated by atrial stretch by increased blood volume. And in fact, that's one of the markers of increased circulating blood volume, is to measure brain natriuretic peptide. So let's go to the physiology of water balance. Water is freely filtered at the glomerulus. 67% is absorbed because it is sodium goes in, water will also go in equal amount. It's isoosmotic. 10% in the loop of Henle and the rest in the collecting duct. So proximal reabsorption is isoosmotic. Water is reabsorbed in the descending limb due to medullary hypertonicity. Solute but not water is reabsorbed along the ascending limb and distal convoluted tubules. And it's variably reabsorbed in the collecting duct due to aquaporin, which is controlled by ADH. This is a little busy slide. I'll just come to the last part, that arginine vasopressin or ADH regulates water secretion, water excretion. AVP secretion is stimulated when serum osmolality increases. AVP secretion also stimulated when EABV volume is reduced. Osmolality is usually predominant regulator of AVP release. AVP regulates water excretion. When AVP is absent, the dilute tubular fluid will just leave the kidney. When AVP is present, it activates V2 receptors on basolateral membrane on collecting duct cells. When AVP is present, water is reabsorbed, driven by medullary hypertonicity. So when you start using diuretics, or when you have tubular dysfunction, there is absence or there is very low levels of medullary hypertonicity that is maintained. And therefore, ADH may not have that much effect, even though ADH is actually present. So with chronic diuretic use and with tubular dysfunction, this is a problem of water excretion. So summarizing the sodium and water balance, you have enteral and parenteral intake in the ICU. The ECA blood volume is actually regulated by extracellular fluid sodium, as well as extracellular serum osmolality, which then controls the total body water. There are sensors that are present in the kidneys, in the cardiovascular system, as well as in the hypothalamus, that will regulate hormones that then control the extracellular fluid volume. The effectors, which are neural, hormonal, and physical, they also will be stimulated by the relative amounts of sodium, water, and osmolality and the extracellular blood volume. And then it results in output, either sodium output, water output, or both of them. So remember, I was talking about the concept of effective arterial blood volume. So if you look at the normal subject, if the patient, this is an adult example, but it applies to children as well. If you have a normal salt intake, then the total ECF volume is normal, total blood volume is normal, arterial blood volume is normal, EABV, which is the effective arterial blood volume, is also normal, and the urine's sodium is also normal, body weight is normal. But when you restrict salt to somebody, a normal person, then total ECF volume is decreased, total blood volume is decreased, arterial blood volume is decreased, EABV is decreased, urinary sodium will decrease because it's completely reabsorbed in the proximal tubule in the kidney, and body weight also goes down because mainly of water weight. Is somebody asking me a question? Okay. In disease states, for example, in burns, sodium intake is high because we give them a lot of fluids. So their ECA blood volume is decreased, but their total blood volume is decreased because it actually dissipates from the vascular space into the interstitial space because of increased permeability. Therefore, the effective arterial blood volume is decreased. So the kidney thinks that it needs to reabsorb sodium, so the urinary sodium decreases. But body weight increases because of interstitial fluid. The same thing happens with sepsis. So burns, sepsis, there is increased capillary permeability. Total body water is increased, total body fluid is increased, but intravascular space is actually decreased. In congestive heart failure, on the other hand, total blood volume is increased, but the arterial blood volume actually goes down. And EABV is the effective arterial blood volume because it's all in the venous side. Because of congestive heart failure, there is venous pooling. And therefore, the kidney thinks that it needs to reabsorb water, and it causes increased intravascular space. And the body weight is increased. In cirrhosis, what happens is ECA blood volume is increased, total blood volume is increased, arterial blood volume is also increased, but the effective arterial blood volume is decreased. And the same phenomenon happens to kidney. So when you do urinary electrolytes in these states, you find that the urinary electrolytes are very, very low. So people think it's a pre-renal state. So the kidney thinks it's a pre-renal situation, but your total body water is actually increased. So this is one way the concept of effective arterial blood volume is useful. So let's go to the meat of the talk. How much time do I have? Lakshmi?
So you have another 10 minutes?
Okay, I'll try to speed up. The definition of sodium hyponatremia is slightly different in different textbooks. Most common is less than 135, the range being 135 to 145. But I've seen textbooks where the definition is less than 136. It doesn't matter. So jumping into the evaluation of hyponatremia, the patient may be either symptomatic with CNS, mainly CNS symptoms, or asymptomatic with just mild symptoms. So if you have severe hyponatremia, we'll go directly to treatment of severe hyponatremia with either confusion, ataxia, or seizures. The most common would be seizures. Asymptomatic, you have time to evaluate the patient. You can classify hyponatremia by determining the serum osmolality into patients with normal osmolality, low osmolality, or high osmolality, but with hyponatremia. So this would be isotonic hyponatremia. This would be a state where you have to consider pseudo-hyponatremia. That is, the sodium concentration in the water component is actually normal, but it appears low because of the presence of other things that increases, that basically decreases the concentration based on the measurement technique. So the pseudo-hyponatremia is important to understand in terms of measurement technique. There are certain, and I will come to that a little bit later. You have to assess for mainly the proteins and lipids are the ones that contribute to pseudo-hyponatremia. Either lipids are very high or proteins are very high. The most common example of proteins being very high would be multiple myeloma. If you have hypotonic hyponatremia, which is low osmolality, then you have to assess the volume status, and we'll come to that part. If your osmolality is very high, that means you have something else other than sodium contributing to osmolality, which could be glucose, which could be mannitol, which could be sorbitol, which could be other things like radio contrast media. So the treatment of hyponatremia, the desired change is immediately change the sodium concentration by 3 to 5 milliequivalents per liter. The most common agent that we use to try to raise the sodium is hypertonic sodium chloride. So hypertonic saline, there are different concentrations. I'm going to use the example of 3% saline. So the sodium dose that you want is the desired change multiplied by the weight in kilogram multiplied by 0.6. We're just going to use 0.6 as that's the most common correction factor that we use. So the volume of saline to be administered, 3% saline to be administered, the actual sodium concentration in 3% saline is 513 milliequivalents per liter. But let us assume it's only 500 milliequivalents per liter for easy calculation at the bedside. So that means it's 0.5 milliequivalents per ml. The sodium change we require, we said 3 to 5. Let's take the lower end, 3 milliequivalents per change. And I've given some weights, then calculated the sodium dose. and then the volume of the 3% saline that I need to administer. If you notice the sodium dose and the volume, it is basically the double the sodium dose. You see, for a patient with 5 kilo, if I want a 3 milliequivalent change, I need a dose of 9, and the volume is 3%, is 18. It's very easy to, so you calculate the sodium dose, just multiply it by 2, and that's a volume of 3% saline that you need, approximate. The actual one would be slightly more than that, but guess what? We want to correct it to 3 to 5, so that's a very good way of calculating at the bedside. You don't have to use the calculator. You can easily do this at the bedside. I don't know how many of you can do it in your head, but you can. So this is a simplified equation that 2 times the sodium dose that you require is the volume of 3% saline that you need. So if you look at hyponatremia, once you come to the low hypoosmolar hyponatremia, there are 2 ways that people have done this. One is to measure FeNA, that is the fraction of excreted sodium in the urine, and then trying to classify the disease states. So you can do it by hypovolemia can be estimated by the FeNA, and then say that is due to extrarenal solute loss, and these are all the causes of extrarenal solute loss. Now, if your FeNA is high, that means you're actually losing sodium in the kidneys. This would be diuretic excess, mineralocorticoid deficiency, salt-losing nephropathy. Now, this could be a kidney that is diseased, therefore it's losing salt, or it could be due to CNS disease, an entity called cerebral salt wasting. And I'm going to make a distinction between cerebral salt wasting and SIADH, which are the 2 most common ones that we see in the ICU. And it creates a diagnostic dilemma. Does a patient have SIADH, or does a patient have cerebral salt wasting? And I'll come to that a little bit later. If you're euvolemic, that means let's say your fractional excretion of sodium is low, then most likely reason is you're just drinking too much water. And this could be a psychogenic polydipsia. It's very hard for a normal person to drink that much water, because you will immediately stop, because you only drink in response to thirst. Of course, I mean, you could force yourself to drink a lot of water, especially if you're intoxicated by something else, which often happens. If your FeNA is high, then you have to suspect endocrinopathies, SIADH, or drugs. So FeNA being high with low osmolality could be cerebral salt wasting or SIADH. So we need to be able to distinguish them. That's very important. If you're hypervolemic and your FeNA is low, generally speaking, remember the effective arterial blood volume I was talking about. It is usually with edematous states where the intravascular volume is affected, is low. So nephrotic syndrome, cirrhosis, and heart failure. If the FeNA is high, then this would be either acute or chronic renal failure. Now, another way to do it is actually looking at urinary osmolality. And you come up with the same kind of classification, either using osmolality or using FeNA. And I won't go into the detail because it's basically the same structure. The only difference is that when you use urine osmolality, you can have either high osmolality, low osmolality, or variable urinary osmolality. And this would be a reset of the osmostat. But whatever I described in the previous slide with FeNA applies with urine osmolality. You could use one or the other. Some people try to use both. So let's go directly into the differential diagnosis of and treatment of hyponatremia. And I will try to finish very quickly. Let's take just pseudo hyponatremia. what I want to point out with pseudohyponatremia is it is only true depending on the measurement technique for sodium. So you need to find out from the lab how they actually measure the sodium. If they use some of the more modern techniques, then there is no pseudohyponatremia. That is actual concentration of sodium. There is, when high amounts of protein are present, sometimes the labs will add water to it to dilute it so that they can actually measure the sodium. That's when you get into pseudohyponatremia. So then the sodium concentration does not reflect the actual sodium concentration. So the idea of pseudonatremia is actually a lab issue. It's not the issue of a true sodium concentration being low in the patient. So it's a measurement issue. So you have to find out from the lab how they measure the sodium concentration. So if you have hypovolemic hyponatremia, I said cerebral salt wasting, it can be diuretic use. Gastrointestinal losses is the most common in pediatrics. You can have mineralocorticoid deficiency. This could be primary or secondary cortisol deficiency. Osmotic diuresis would be from a mannitol use or elevated glucose levels, renal tubular acidosis, and salt wasting nephropathies. And third spacing from burns, sepsis, or bowel obstruction. So this is the diagnostic criteria, and the treatment for cerebral salt wasting would be saline. For diuretic use would be to stop the diuretic therapy. Intravenous fluids would be for gastrointestinal or replacement fluid by oral rehydration therapy. And for mineralocorticoid deficiency, we wouldn't try to correct the sodium, but give the steroid replacement therapy. In patients with DKA, you would just correct the glucose levels. If you're using mannitol to treat intracranial hypertension, இல்லையே அடிபடலையே யாரோ scratch பண்றோம். Okay. Renal tubular acidosis, and you correct the underlying cause intravenous fluids. Hey, somebody's done something to the screen. Okay.
Someone is doing annotation.
Annotation, okay.
Yeah.
I hope it doesn't come up in my screen. Okay. If you're euvolemic, then it could be in the West, we see a lot of amphetamine use. I don't know if you see that in India, abuse by adolescents. This is an adult stuff, excessive alcohol consumption. Maybe, I don't know if it's present in pediatrics in India. These are not that common. Nephrogenic SIADH, SIADH due to CNS disease or other diseases. That is the most common reason for euvolemic hyponatremia. If you have hypervolemic hyponatremia, it could be due to hyperaldosteronism, which is commonly seen. Secondary hyperaldosteronism is seen with liver failure. Iatrogenic can be just we give too much fluids, the containing salt, which happens when we overestimate what they need, their fluid needs are. So differentiating SIDs from renal salt wasting or cerebral salt wasting, which is basically the same. The volume status, they are actually hypovolemic. So you would see clinical signs of hypovolemia in these patients. So skin turgor may be decreased, capillary refill may be increased, their extremities may be cooler. Urine output would be actually normal to high in renal salt wasting or cerebral salt wasting states. Whereas we know that urine output is low, they're oliguric with SIADH. And urine creatinine to uric acid will be low, and it will be high in the state. Plasma osmolality is decreased in both. FeNA is increased in both. Plasma renin activity, if you can measure it, will be low in SIADH, will be high in this. So generally speaking, we only look at these four things in the middle. Two things in the middle: urine plasma osmolality and FeNA in most patients. They will be the same in these two states. So the distinguishing feature would be the urine output and the clinical exam suggesting euvolemia or hypovolemia. So people have tried to classify hyponatremia by different criteria. So I showed you some using osmolality or volume status. But the problem is they all have limitations in terms of clinical utility. For example, if you use this moderate to severe, symptoms do not always correlate with the degree of hyponatremia. It seems more related to how fast the sodium actually goes down rather than the actual level of sodium. Acute versus chronic, often we don't know how long it took for the sodium to actually go down, even with a good history. Many symptoms are non-specific. Chronic hyponatremia actually may be more symptomatic than acute hyponatremia in some patients. We don't measure the other osmoles. So it is important also to look at the osmolality gap or osmol gap in the serum to find out if you have other osmoles being present. And clinical assessment of volume status has very low sensitivity and specificity. Not all patients will present with some skin turgor or issues when you do cerebral salt wasting versus SIDH. So equations used in managing hyponatremia to estimate the effect of 1 liter of any infusate, the change in sodium concentration is equal to the infusate sodium level minus the serum sodium level divided by the total body water plus 1. And to estimate the effect of 1 liter of any infusate containing sodium and potassium, you use this equation. So what are the sodium concentrations of various fluids used in pediatric practice? These are the ones. 3% saline has 513 milliequivalents per liter. Normal saline has 154. Ringer's lactate has 130. Half normal saline has 77, and quarter normal saline has 38.5. So does the rate of correction matter for complications? This study in adults showed that it does. We don't have similar studies in pediatrics, but we believe this to be true, that in chronic cases, very slow correction did not result in any complication in this particular retrospective study, whereas rapid correction did produce transient sequelae and permanent sequelae. Whereas in acute cases, they didn't see any sequelae. But we have seen patients with acute correction in pediatrics with central pontine myelolysis. These are some selected formulas. Since you're going to record this, I'm not going to go through these formulas because they are fairly complicated. Some of them are for hypernatremic states, correction. There is a very simple formula for hypernatremia. Maybe after Uma's talk, we can discuss that. There's a very simple formula at the bedside that you can use. There is a very nice video summarizing how to evaluate hyponatremia. Most of it applies to adults. Some of the disease states applies to adults, but the general approach is very relevant for pediatrics as well. I found this to be very, very, very simple, easy to understand video, and the person who has put together this video goes through step by step. I hope I didn't take too much time. I'm done.
Thank you so much, sir. Thank you for those very in detail explanation on how the renal tubules work, the effective arterial blood volume, and I'm sure all of us have learned more from this talk. I invite Dr. Umali to go ahead and present her talk then.
Yeah, can you permit me to share the screen, please?
Bhavik?
Yes, sir. Ma'am, you can share your screen.
Okay, thank you.
So what I want to share with you is Uma, Ali, and I have known each other for more than probably 25 years, I would say. I would venture to say.
Yeah,
20
probably, yeah.
Close to 25 years. For the young people, if you want to be an expert in a particular area, it's not possible to be an expert in every area in intensive care, but you can become an expert in a particular area. I think Dr. Uma Ali would be an example of how you can become an expert in one particular area. Her talks on nephrology, her talks on renal diseases, every time I listen, I learn something new. So she is a self-taught and expert on nephrology. She didn't. I don't think you did a fellowship in nephrology, Uma.
No, I'm an untrained nephrologist.
No, you are a full you qualify as a fully trained nephrologist. You're doing exactly what the nephrologist would suggest to us. Maybe with a little taste of intensive care, looking at the whole patient. Generally speaking, subspecialists look at only their system and not look at the whole patient. So we are fortunate that somebody who looks at the whole patient is also an expert in kidneys. Okay.
Thank you so much, Shekhar. Yeah.
I thought I would share that.
Yeah. Thank you so much. I think just because we do have a lot of new fellows, I think, in the audience, what is osmolality and tonicity? I just want to be on the same page. Osmolality is the total concentration of all particles in solution, much like democracy, everybody has one vote. And tonicity is what happens at the ground level, that the osmotic activity of the impermeable particles are more important than all the particles because they allow you to pull in water. Okay. Now, we all know this formula, 2 sodium plus glucose upon 18, urea upon 28. And when we see tonicity, we don't count urea because urea diffuses freely across the membrane. So we are counting sodium and glucose, of which you can see sodium is twice the sodium value, which is already high in the blood. So sodium is the star of tonicity. So changes in sodium will have a serious impact on the tonicity. And tonicity is important because change in tonicity affects cell volume. And cell volume changes lead to cellular dysfunction and can even lead to cell death. Now, maintenance of cell volume is a fundamental property of all living cells. And it has been highly conserved throughout evolution for 3.5 billion years, since the first prokaryote appeared in the waters that gave it life, but also threatened its integrity. So the primitive cell had 2 important needs. It had to get its nutrients from the surrounding water, but while doing so, it had to preserve its unique biological identity under an isotonic external milieu. So if it was in fresh water, it was at risk of swelling. If it was in salt water, it was in the risk of shrinking. And we know that acute rise in serum sodium leads to water shifting out of cells and shrinkage of cells. And shrinking of cells can activate the apoptotic pathways leading to cell death. So what are the mechanisms of protection at the cellular level? That right from the prokaryote to mammalian cells, there are 2 important properties on all cell membranes. One is a free permeability to water because of constitutively expressed aquaporin, and limited or no permeability to solutes mediated by specific pumps and transporters. The most ubiquitous one is the sodium-potassium ATPase pump present on most cells. Now, what were the evolutionary changes? That we took the environment with us so that we can move all over the world. So now we have an internal milieu and we have to fine tune it with homeostatic mechanisms to maintain constant tonicity of the milieu so that we protect our cells from either swelling or shrinking. And the two things that help to maintain this milieu of intact tonicity is intact kidney function and intact ADH mechanism. So if any one of them is defective, we fail in maintaining homeostasis. Now, when we see the homeostatic mechanisms we have, our normal serum osmolality, if we take as 280 milliosmoles, it's maintained within 1% of normal. That means if you have a 3 milliosmol change, you will have a rise in 1% of serum osmolality, and it will stimulate the secretion of ADH. And a decrease by 1% will inhibit ADH. Now, ADH levels closely related to urine osmolality. So urine osmolality reaches its maximum of 1200 milliosmoles when ADH becomes 5 picograms per ml. And this corresponds to a serum osmolality of 290. So you can see it's a very small range and you've already reached maximum urine osmolality. And now increase of serum osmolality beyond this will continue to increase ADH to a certain extent, but not the urine osmolality. The urine osmolality will plateau at this point because it's already reached its maximum. At 290 osmolality, stimulation of thirst occurs. So that means nature has an inbuilt ADH mechanism because it does not trust that the environment might have water for us to access so fast. So the internal homeostatic mechanism kicks in a little earlier than the thirst mechanism. And this is the same thing shown graphically, that you can see at 280, you have a start of your urinary concentration, and you can have your osmolality also increasing correspondingly, the vasopressin levels. At this point of 290, your urine osmolality is already reached its maximum. Now, osmotic disequilibrium is brain stress. You have a stressed out brain by this anisotonic condition. And why? Because if you have a hypertonic stress, there's rapid shrinking of the brain because the brain is attached to the skull and the brain retracts 3 to 6 millimeters below the table of the skull rapidly. This increases the stress on the falx cerebri and venous sinuses, leading to subdural hemorrhage. Tearing of intracerebral veins can lead to intracerebral hemorrhage. Capillary venous stasis occurs throughout the brain. Pycnotic nuclei in microglial cells and neurons at the ultrastructural level. And you can also get osmotic demyelination. We always think of osmotic demyelination when we correct sodium fast. But even the natural or the pathological rise in serum sodium without an iatrogenic interference, if it rises very rapidly, can in some cases cause osmotic demyelination by hypernatremia per se. Now, what does the body do to adapt? Because it cannot afford this volume changes. So, because hypertonic states tend to reduce brain volume, the brain has to adapt almost instantaneously to protect itself. So there's a rapid shift of electrolytes, mainly sodium, potassium, chloride into the cells. And where do these come from? The sodium and chloride comes from the interstitial fluid into the cells and the potassium from the plasma into the cells. So there is this, so it restores volume to a reasonable extent. So the loss of volume which we expect is much less than that predicted by rise in osmolality. Now this effect is seen within a few minutes, but it's a limited response. Now this shows again that when the osmolality increases within few minutes, you have a rapid loss of brain volume. This is the cell volume which you're seeing on the y-axis. And you can see it occurs very rapidly. And almost when it reaches its peak, you start restoring volume by electrolytes coming in. And within few minutes, this has reached a peak, after which there's a steady small accumulation which further occurs. Now, this is not sufficient, or it is not actually ideal or even reasonable for the brain, because these are all electrolytes. And the excitatory and other activities, neuronal activities, are dependent a lot on ionic concentration, so it can greatly distort the function of the CNS. So the brain needs some other osmolytes which will not be charged, but which can give enough particles to retain water. So when you have a hypernatremia which is lasting from hours to days, then you start accumulating organic osmolytes. Now these are small, non-ionic, that means they are not charged solutes, the accumulation of which we believe does not interfere with metabolic pathways of cells. But that is like a over-optimistic thought process, because nothing is redundant in nature. So these osmolytes do play some cellular functions which are important in terms of protein folding, unfolding, etc. But compared to the disturbance produced by electrolyte influx and outflux, these are more tolerable to the brain and less disastrous. So the major osmolytes are glutamine, glutamate, taurine, and myoinositol. And you have a whole lot of other minor osmolytes also, which add into this picture. These are either generated from within the cell itself, or they're transported from plasma through sodium coupled transport. It's a slow process and it requires 2 days to reach a steady state. Okay? So if you see now what is the brain looking like, you have, although as the organic osmolytes enter, some of the electrolytes are pushed out, still at the end of the day, there is an increase in the electrolyte content. And these are the host of organic osmolytes, which we already mentioned, which are sharing space to maintain cell volume. So to just summarize the thing, this is the stressed brain with the hypertonicity, and it is going to shrink if uncorrected. And this rapid shrinkage sets in electrolyte entry, so that there's a rapid volume increase within a few minutes to restore volume to a better level, and a chronic adaptation which takes 2 days, during which osmolytes accumulate and electrolytes are effluxed. Okay. Now, the reverse occurs, the same thing you have to consider when you are de-adapting. That means now you're correcting the hypernatremia. Your milieu is no longer stressing for shrinkage. So now the electrolytes, like it came in, can move out fast. But the organic osmolytes will take time. So some of the organic osmolytes like taurine, betaine may move out within 2 hours, but some of them have known to take as long as 48 hours to move out. So there are effects of hypernatremia beyond volume. So some of the ones which we see at the bedside is hyperglycemia, because it inhibits insulin-mediated glucose uptake. So this also translates into decreased glycolysis and decreased production of ATP. It increases calcium uptake. It also has pro-inflammatory and anti-proliferative actions. But very important is it can stimulate apoptosis by shrinking. And there are elevated levels of various pathways of apoptosis, which are known pathways like tumor suppressor P53, caspases, etc., which lead to apoptosis. And we usually do not think of the other organs because the impact of the brain is so catastrophic, but hypernatremia has effect on other organs. So this is what we see about the brain: cerebral shrinkage with risk of vascular rupture. Clinically, you will see as restlessness, seizures, coma, but you can have cardiac decrease, left ventricular contractility. You can have hyperventilation. You can have disturbed glucose utilization, impaired gluconeogenesis in the liver. And in the muscles, you can have rhabdomyolysis, which could be one of the causes for acute kidney injury in these children. And we all know that the pediatric brain is more vulnerable to osmotic stress than the adult brain because of the relatively large brain compared to the intracranial volume. So the brain reaches adult size by 6 years, but the intracranial volume reaches adult size only by 16 years. So the brain is a tight fit in the skull. Now, what are the clinical applications in PICU? So when we see hypernatremia in PICU, so we know the pathogenesis of any hypernatremia is either more sodium, less water, or sometimes a combination of more sodium and less water. So because we know that what we are measuring is a concentration. So it has a numerator, it has a denominator. So changes in any will affect the concentration. So the first scenario, which is rare, is where there's pure salt intoxication, which is rare, and but because you might see it in emergency ICU once in a way, one needs to be mentally prepared for it. So the lethal dose of salt is about 5 teaspoons in children, 4 tablespoons in adults. And there are very few published reports, and they are mainly due to salt water being used as emetics, which is there in many cultures. Non-accidental poisoning by caretaker, by giving over concentrated formulas, or by mistake adding salt instead of sugar. Sorry, those are accidental, but there's non-accidental poisoning which can occur, which needs to be kept in mind. People have also presented this because it's a ragging or it's a challenge, and people have tried to commit suicide taking soya sauce, which has very high sodium content, especially the Japanese one, and inadvertent concentrated formulas in infants when they've changed formula in an improper preparation. It's very rare relatively, but it's an acute emergency. It's always short history. It's not something which happens over days. Catastrophic presentation with major CNS manifestations. Usually the sodium is very high because the level of poisoning is so high that the body does not have mechanisms to compensate for this. There's no dehydration. You could get puffiness. If you do a fractional excretion of sodium, it'll be more than 2%. And the treatment, if there's good renal function, could be hypotonic fluids, diuretics, and the invent of very high sodium or AKI accompanying, which is not uncommon. You should resort to dialysis, and mortality is almost 50%. The other extreme, where you have pure water loss. Again, just having pure water loss in the ICU is not so common in a general PICU, but could be fairly common in a neurosurgical PICU, so depending on what you're draining. So you see a central diabetes insipidus as a classical example in traumatic brain injury, transphenoidal surgery, of course in brainstem death. And you have classical polyuria, which is usually much more than the cutoff of 4 ml per kg per hour. Urine osmolality is less than 100 or 150. And of course, you have hypernatremia, which is your clue. And I'm not sure why it's not moving. Just a second. So I'll just proceed while the slide seems to be a little stuck at this point. The treatment for it again is by vasopressin infusions. When you try to chase this water by replacing free water, you just end up excreting more urine, creating more polyuria, and you never reach anywhere. So as soon as you diagnose, you start a vasopressin infusion. It's saying the shared windows closed. Can you allow sharing?
Ma'am, it's allowed. It has not been stopped.
But that's the message it is giving me.
Avik, unshare and share again.
Yeah.
Okay, well, it's opening. So you give vasopressin infusion, start with the low dose. Make sure that once you've started vasopressin infusion, you are not trying to replace urine volume. And you're not giving dilute maintenance fluid, which you may have done earlier. So you need to give more concentrated solution in smaller volumes and don't replace the fluid. I'm sorry for this. I'll just get back.
Ma'am, can you try sharing the screen again?
Yeah, I'm just doing that. Okay, this is my screen is on. Can you see? Hello?
No, ma'am, we cannot see. You will have to share it.
Can you make Madam co-host?
Yeah, I've made her a co-host.
No, Madam.
If that helps.
Is it visible now?
No, ma'am.
Okay, I don't seem to have the zoom at all here. Okay. 1 second, yeah. I think I got it.
I can see you, madam. Yeah, it's not.
Yeah.
We can see. Yeah, it's come.
Okay.
Done. Good.
So I'll go. So we target a urine output of 2 ml per kg per hour, a specific gravity about 10, and monitor serum sodium 2 hourly. Okay. Now I come to important ICU related issues where these are little rarer, but most commonly the hypernatremia we see is a combination of more sodium and less water. And what are the salt sources in PICU? We know all the salines which we use. And there are few which are very high sodium content, like sodium bicarbonate with 1000, sodium chloride with about 500. But what we don't look at is the salt in medications. There are a number of antibiotics which we use, which are high in salt, and in the high doses we use, they would be also contributing to the sodium intake. The other flip side is, do we have electrolyte-free water losses? And that we'll have to look at renal and non-renal losses. Renal losses, we already spoke of central DI. Acquired nephrogenic DI due to electrolyte disturbances like hypercalcemia, hypokalemia, or drugs is important to keep in mind. And most common cause of renal losses is an AKI, which is non-oliguric. Or you may have an osmotic diuresis, either due to glucose, mannitol, urea, or sometimes rarer things. And the non-renal causes are due from your skin evaporative losses and GI diarrheal hypotonic losses. Now, the clinical questions we ask ourselves is, how rapidly should hypernatremia be corrected? How do we calculate deficits or excess? Formulae for correction of free water deficit, which should we use them? And when should we not use dilute fluids? Now, how rapidly or slowly should we correct hypernatremia? Now, acute hypernatremia less than 48 hours duration, it's not can, but should be corrected rapidly because you have fairly severe damage secondary to hypernatremia per se. So this has been well shown in adult literature, whereas chronic hypernatremia has to be, or which is more than 48 hours or unknown duration, we presume is chronic. So we need to correct slowly to prevent therapy-induced cerebral edema, herniation, and death. So we allow for gradual de-adaptation, and the decrease in serum sodium should not be more than 0.5 milliequivalents per liter per hour. These have come through mainly pediatric studies which have shown that below 12 milliequivalents per liter per day does not cause seizures and other CNS problems. No rapid correction. Administer your planned correction in 24 equal installments. Prefer enteral correction where it is possible. avoid fluid boluses unless hypotensive. Now, how do we calculate deficits or excesses? We're used to calculating by this formula of total body water deficits. But the right way to do it in ICU patients would be to use a tonicity balance, because we have already intervened in this child doing a number of things which have somewhere added and resulted in hypernatremia, and we need to look back to see what have we done. And this we get by a tonicity balance. As since sodium is not a single compartment, the least we can do is consider it as part of two compartments, the intracellular and extracellular, because when you give potassium into the blood, it will go into the cell and it will push out some sodium. So they are total body exchangeable sodium potassium. So you look at the balance of sodium potassium in minus sodium potassium out, and your fluid in and fluid out. Okay. So just a brief scenario. This is a ARDS child on mechanical ventilation. Earlier she was in shock, resuscitated with fluid bolus inotropes, presently maintaining good perfusion on reducing inotropes, stable ventilation. And routine electrolytes now show a serum sodium of 154, whereas the starting was 140. So what has caused this? Is sodium excess? Is it fluid deficit? Clinically, child is mildly puffy, but we don't know the intravascular volume. Has she translocated all this fluid? Her serum albumin is low, and all of us know the difficulties of estimating volume in ICU patients. So we don't know the volume status. So I'm sorry, this I think is the older presentation. So one thing is missing. So what we do is this is just a representative table and not the actual values from this child. So you take what was your fluid input in the last 48 hours before you discover. So that all the fluids that you gave, you keep entering. The column that is missing is from each of this, you put down what is your electrolyte free water which you've delivered. You put all the sodium you've delivered, you put all the potassium you've delivered, so you get your net fluid and sodium and potassium which has gone in. And you do the same for output. So whatever are your outputs, urine output, drain, everything, volume, electrolyte free water, which sorry, it's missing from here, sodium, potassium, and the sodium plus potassium, which it comes to. And then you see the net balance. When you put the net balance, what we are seeing is that the fluid that has gone in is much more than the fluid that has come out. So there's a 225 positive balance. And there is also a 80 milliequivalents positive sodium balance, which has gone in. The electrolyte free water should be in the third one. So you'll know that how much of that is deficit. So if you see what is the final conclusion after we do the tonicity balance, that this child has a volume excess of 225 ml. There's a sodium excess of 80 milliequivalents per liter. There's a hypervolemic hypernatremia. So what we need to do is give furosemide to remove the excess sodium and water, and we need to give hypotonic maintenance fluid. Now, if we do not calculate, our reflex action is to calculate water deficit and start giving that extra water, which may dilute some of your sodium, but may leave the child more fluid overloaded. Okay? And you may not reach, because you've done nothing for the sodium, that all that sodium is still in the body and it will show up again in another form. Okay? So the last scenario I'm putting over here is to basically focus on what is the kidney doing in this situation. Okay? Because this situations comes up obviously because your homeostatic mechanism is not intact. If your homeostatic mechanism is intact, when you go to hypernatremia, you should have a urine osmolality of 600 to 800. Okay? And you should have high sodium plus potassium because you have to excrete that excess. Okay? So now this is a 9-year-old girl who was operated for an abdominal emergency, had to undergo a second surgery, developed post-operative sepsis repeatedly, twice bloodstream infections, resuscitated again with fluids, inotropes, ventilated. Due to intestinal failure, she was on TPN, developed AKI with fluid overload, needed CRRT for 3 days. Currently not on inotrope. The AKI improved, and now the child is passing urine 6 ml per kg per hour. So she's on the improving side. But what has happened is the sodium has increased from 140 to 155. So we didn't want to go through a lot of complication. We just changed the extra fluids we were giving from full NS to half NS, but we find that sodium is still creeping. So we made it into D5. So that made it static, but didn't bring down the sodium below 160. So step 1, we looked at what is the urine osmolality. So it's only 400. It should have been 600, 800 with that 160. So it's not doing its job. Basically, because although the AKI is improving, there's a lot of tubular dysfunction still present, which may take a long time to return to normal. Okay. Second, we want to know, okay, now is kidney the root for all this loss of free water? So simple way of looking at it is look at the urine sodium plus potassium and see the serum sodium plus potassium. If your urinary electrolytes are less than your serum electrolytes, this is actually should be a 24 hours urine sample, then you're losing free water because you should be having a concentrated urine with high electrolytes. You're having lots of urine with low electrolytes, so you're losing water. You can also calculate how much free water is excreted. This is for planning your therapy. There are formulae for it, which Shekhar already mentioned, and it's there everywhere, so I'm not going to go into it. And my last step would be that is there an osmotic diuresis in this child for some reason? Why is there so much free water going? Is something else dragging it? And if you look at what can drag it, it's glucose, mannitol, and urea. We've not given mannitol. This child is not hyperglycemic, urine glucose is absent. So my focus is on urea. Okay. And how do I see? We did this again. So the next day, the osmolality was 554. Now, when we calculated the osmolality that will come from the electrolytes, that's twice your sodium, potassium, it was only 230. So there was 324 milliosmoles in the urine that is unaccounted. So we measured urea, and when we translated that into milliosmoles, we found that almost 248 milliosmoles was coming from urea. And then we did the BUN, and it was 124. So although the creatinine had come down to 0.89, and so the high urea comes from catabolism. This was a post-operative child, 2 surgeries, 2 bloodstream infections, extremely catabolic. Also renal failure, so high urea still retained, and TPN with high proteins, which was generating urea. So urea competes with sodium for excretion, and it's a common cause of hypernatremia in ICUs. So what we did was stop TPN for 2 days, did the deficit correction by giving her enteral water hourly. We made the maintenance into 5% dextrose with only the KCl she needed, and replaced the excess urine output with half NS, which was matching the sodium potassium content of the urine. So match the urine volume and composition by. So now after 24 hours, we got a drop in sodium of 9, and another 48 hours, we got a 10 drop, and we had restarted TPN with lower amino acids. Okay. I'm not going to go through this because I'm sure it'll be discussed in the cases, except we need to look at what is the free water content of the various solutions we are giving for IV. So finally, we need to look at when do we not use dilute fluids. Okay, so you have to see what is your homeostatic mechanism in place. If you have polyuria, most likely you don't have a homeostatic mechanism in place and ADH is not acting. So confirm it, you'll have low urinary osmolality, you'll have low urinary electrolytes, or urinary electrolytes will be less than serum. So only give hypotonic solutions because this child cannot tolerate any sodium. If you have extra renal losses through GI or skin, your renal and ADH is intact. So you have good homeostatic mechanisms in place. ADH is acting, kidney function is normal. You will see oliguria, you will see very high urinary osmolality, more than 600. Your urine electrolytes will be high because that's what the body needs to do. Your urine sodium plus potassium will be more than serum sodium. And all the free water is reabsorbed. Then why is this child hypernatremic? Because we are not allowing him free access to water and for his thirst to do the job. We are trying to be his hypothalamus and we fail miserably. Okay, so here giving a dilute solution can cause catastrophic drop in serum sodium, because to put it very briefly, your normal 150 sodium, 150 chloride in 1 liter of water is giving you 300 milliosmoles. Now here you have an ADH which is now highly stimulated and you have 600 milliosmoles. So what your kidney does, it has to excrete it in 600 milliosmoles. So it will excrete that sodium in 500 ml of water. So it's actually from the 1 liter you have given, it is generating 500 ml of free water and putting it back into the system. Okay. So from your sodium, even when you give isotonic saline, you may generate free water if your ADH is very high. So this is called generation of free water by the kidney by desalination. So here, if you give dilute solution, you're going to have a in 6 hours, you'll normalize your serum sodium, but you might lose your brain. So when you have unstable hemodynamics and you need to restore intravascular volume deficits, you have to use isotonic saline, but you avoid bolus unless the child is hypotensive. Give 10 ml per kg normal saline over 1 hour, similar to how you treat a hypertonic DKA. And if serum sodium is very high, say 180, 190, 200, you may actually increase the sodium levels of the fluid you're giving so that the delta between the fluid sodium in the body and the fluid given is not more than 15 or 20. Lastly, I'll come to this, that why is everything we calculate goes wrong? Okay, you do all this, you will still find that your predicted fall is not happening because our understanding of the pathogenesis is very simplistic, whereas in the body, the sodium is very complex. So we have the small intravascular compartment, which the size of a shaker has already said. We are trying to manipulate this through IV fluids. Most of the time, we don't even take potassium into consideration. Just take sodium and water and think that's going to do the job. You have the intracellular compartment, which is much larger, where the main thing is potassium, and they will interchange. So we have to take sodium and potassium and at least do a double compartment calculation. I think yesterday Andrew gave a brilliant talk of interstitial fluid and the lymphatics. So we have another dimension which we have not explored what it is doing. And we also heard about the non-osmotic sodium, that sodium, a large compartment in the skin, which has a large amount of sodium, which is not osmotically active, but which may be taking or releasing sodium, which we do not know as yet how it acts. And a deeper compartment in bone, which appears not to interact at all. So there's lots in sodium we do not know, we do not understand. So we are using very simplistic solutions, and that is why we have problems. But still, in the vast majority of clinical medicine, the body mechanisms being so strong, it compensates for the errors that we make. So in conclusion, I would say the brain is the principal site of clinical manifestations of hypertonicity. Hypertonicity as well as the impaired de-adaptation both can lead to irreversible brain damage and death. Proper management of hypertonicity is therefore critical. And for proper management of hypertonicity, we need to understand the pathophysiology, what's the severity of the deficit, what are the adaptive mechanisms that have already come into play, what is the compensatory mechanism intact or deficient, and understand how it has occurred using a tonicity balance so you address the right components. And these physiological considerations will determine the crucial qualitative and quantitative aspects of therapy. So I'll conclude just as a reminder that pathophysiology of hypernatremia in ICU look at the sodium intake from all sources, including medication. See if there's an inability to concentrate urine, then the kidney is to be blamed. See if there's a high urea excretion, because mannitol and glucose, you can eyeball it and you know it's there. And these are settings which have high urine output. So high urine output is not always a good thing. It might lead to a lot of sodium imbalances because that high urine output may be coming out of renal dysfunction or inadequate ADH action. Okay. So I'll conclude at this point and we can go further.
That was an amazing talk, madam. As many times as we hear from you, there's always more to learn, and there's always something which we had probably forgotten sometime, even though you taught us. Thank you, madam. There are a couple of questions for hyponatremia. Do you want me to take them now, or do we go ahead with the cases, Amish?
Take it now, no? Give them.
Yeah, we can take the questions.
Okay, so one of the questions was about how do we explain the physiology behind hyponatremia in DK and its relation to chloride levels in DK.
Okay, that's that's by itself a 20-minute talk.
So you have 2 minutes.
Okay, in 2 minutes, I'll speak fast. The problem in DKA is you can actually have true hyponatremia due to the osmotic diuresis. You can lose a lot of sodium in your urine and actually have hyponatremia. And you actually lose more water because of the osmotic diuresis. And therefore, relative loss of water is higher. Relative loss of sodium is higher. And therefore, you can get hyponatremia, true hyponatremia from DKA. The other part of the problem is that depending on how you measure the sodium, you may have pseudo hyponatremia, which is the sodium concentration is normal, but because of high glucose concentration, it appears that it's lower. The problem is it's very hard to distinguish the two by just looking at serum levels. Like Dr. Umali suggested, you may need to look at urinary concentrations of electrolytes to actually sort out the difference between the two. Number one. As far as the chloride is concerned, in acid-base balance, in extracellular fluid, electrical neutrality is always maintained. Across cell membranes, osmotic neutrality is always maintained. Whereas within the extracellular fluid, it is electrical neutrality that's always maintained. That means when you lose bicarbonate because of acidosis, it has to be replaced by an anion, which is easy anion is chloride. So the ionization increases for chloride, and therefore you get a relative hyperchloremia. And the most common solution that we use for initial replacement of fluid and fluid management in DKA is normal saline, which has 154 milliequivalents of chloride. And therefore, you are adding to the chloride load of the patient. And we see this in our unit very often. Overnight, their ketones are gone, their beta hydroxybutyrate is normal, yet they are acidemic and acidotic. And that's hyperchloremic acidosis. And people think that this is due to DKA not getting better. It's not. It's iatrogenic hyperchloremic acidosis. So that is why you have to keep track of the chloride level when you manage DKA. And as soon as it starts hitting 100, you should change the fluid so that you give less chloride. If you give a lot of chloride, your bicarbonate will not be restored. Does that answer in 2 minutes?
I think it does. Dr. Umali, madam, there's a question which says, how do we clinically correlate when textbooks say that sodium correction should never exceed more than 12 milliequivalents per liter per day? I think it works for both either hypernatremia or hyponatremia. So would you like to answer that?
I think one has to stick to that because that is what we know. Okay. And even though for hypernatremia, there may not be that much evidence to support it, it's the safe way to do when you think it's been there for some time and not an acute hypernatremia. The only way you can be sure is frequent monitoring. So you have to do, say, once in 4 hours if you do the sodium, then you get an idea. If your sodium has fallen by about 2 milliequivalents from what you started, you know it's about 0.5 per hour. If it is fallen by 4, then whatever you're doing, go less on the free water. As I said, no calculation is perfect. The calculations are imperfect. Our knowledge is imperfect. Our application is worse. So best is to monitor, and whatever you're giving, lessen that free water.
I would add one more thing. Whether you're correcting hyponatremia or hypernatremia, if it is slower than what you anticipate or what you calculate and estimate, it's okay. Don't redo the correction to make it faster. If your correction is faster than what you estimated, then you slow it down. It's okay to correct it. Let's say you planned for 48 hours of correction for hypernatremia, but it's for some reason it's taking 72 hours. It's okay. So the slower correction, let it go. The faster correction, fix it.
There's one more question which is often encountered, especially with hyponatremia. Patients are on IV fluids. We want to do urine sodiums. Whether the child has received a Lasix before. We don't know those things sometimes, and then whether we should be looking at FENA, whether we should be relying on that urine sodium.
No, see, my approach is this. If you have normal kidneys, you should expect a certain kind of response. You can look at specific gravity. You don't need to do a lot of urinary electrolytes. If you're hyponatremic and you're correcting it, you're supposed to lose a lot of water and retain salt. That means your specific gravity has to come down. If you're correcting hypernatremia, the opposite would be the case, that you want to get more water in and more salt out, your specific gravity will go up and your urine output will go up. So if your anticipated response is not happening, or the second part would be you have a clinical situation where you anticipate renal injury. Now you don't know how the kidneys are actually handling your salt and water. That is when you need the aid of urinary electrolytes. So if you are encountering sepsis and you resuscitate a patient and you're encountering hyponatremia or hypernatremia, then that is a patient I clearly would look at urinary electrolytes. If somebody comes in with diarrhea and dehydration, that's not a patient where I would normally check urinary electrolytes. Maybe Uma has a different approach.
No, not really. I think one thing is very clear, that diuretics will alter interpretation of urinary electrolytes. So if you've given mannitol or furosemide, you may not be able to judge the sodium response which is there. So it is prior to giving diuretics. If you have hyponatremia, then your body should conserve sodium. So that is your expected response. So if your body is not conserving the sodium, then probably you have in an inappropriate antidiuretic hormone response where all the sodium you're giving is coming out and water is being retained. Okay? So everything is very contextual when you're interpreting urinary sodium. It is very dynamic. It is for that time what is happening. Okay? So if 6 hours before you've given furosemide action might still be waning, so you may not be able to interpret it.
The other point I would add about diuretics is it depends on whether it is an acute dose of diuretic versus chronic use of diuretics. When you use chronically, I have seen patients not develop hyponatremia, but actually hypernatremia, because the kidneys are avidly reabsorbing salt. And we have a lot of patients where they are hypernatremic, but they're on chronic diuretics. And when we look at it, it's because they are losing a lot of water in the kidneys and their tubules don't function very well. And so that is something that you have to keep in mind when you're using chronic diuretics. Acute diuresis is a different matter.
Thank you so much for all those answers. Dr. Umali ma'am, could you write Dr. Kanavanand to present the cases? Dr. Shekhar would be moderating.
Yeah, now after
There was a question, if sodium dropped more than what I want, should I give 3% to raise it quickly? It depends on how big the drop was. If the drop is only just above what you anticipated, then you decrease the correction. If it is much more and the patient is actually becoming symptomatic, then you can give 3% saline and raise it.
So I think with this, we'll go on to the next part of the session, which are case discussions. And I invite Dr. Kanavanand, who's a senior consultant at Gangaram Hospital in pediatric nephrology and a transplant physician. And I request him to present his cases on hyponatremia. And I would ask Dr. Shekhar to moderate the session.
Go ahead, Kana.
Can I share my screen?
Yep.
Bhavik?
Yeah, sir, he can.
Yeah, go ahead.
Can you see the slide?
Yeah.
Yes, we can, sir.
So thank you, Dr. Umali ma'am and Dr. Shekhar for the invitation. And I'd like to thank the intensive care chapter of Mumbai for inviting me for this talk. And before I start, I'd like to tell Dr. Umali that although you said you are an untrained nephrologist, but then we still consider you as our teacher. So with this, let me start the case studies. Case number 1, it's a 2.5-year-old female child brought with complaints of right-sided hemiparesis with no previous significant complaints related to the present illness in the past. The child was evaluated for the cause. The CT head showed a large infarct in the left MCA territory. MR angio showed block in the M2 segment of the left middle cerebral artery. As you can see in this picture, the angiogram, there was a block in the M2 segment, resulting in the hemiparesis on the right side, and this infarct can also be seen in the film. This case I've shared from my ICU colleagues. So finally, this child was initiated on heparin infusion, and the samples were sent to rule out any hypercoagulable state. The lab parameters showed anti-cardiolipin antibody to be positive. Further course in the ICU remained stable, and the child was shifted to ward after 72 hours. On the 6th day of admission, the child has a seizure activity in the ward, decortication and hyperventilation. Immediately shifted to the ICU after control of seizures. Required ventilatory support. Workup was sent to rule out the cause of the seizure, and the repeat CT was also planned up. The repeat CT showed increase in the infarct size and a shift of the midline on the contralateral side. The immediate sodium that came in after sending the renal functions showed that the sodium was 118 along with seizures. The child was given a correction of 3% saline, as told by Dr. Shekhar, usually the dose is around around 5 to 6 mLs per kg. So 65 ml of 3% saline correction was given for the weight of around about 13 kg for the child, and it was given over a period of 1.5 hours. Subsequently, the plan was to continue with calculate the sodium to be given to this child as per the sodium deficit, and so that the correction can be done over the next 24 hours. So if we see the correction model that we use, the formula is sodium deficit in milliequivalents is equal to the fluid deficit in liters into the proportion of the extracellular fluid into the target sodium concentration in the equivalent. So according to this formula, if we calculate for our child, the fluid deficit was almost for 3% weight loss, which we had calculated as per the current weight as well as the admission weight. When we compared, there was almost 3% weight loss. So it was coming on to around 30 mLs into the weight, that is around 0.39 liters. So sodium deficit was 0.39 into 0.6, that is the 60% of ECF, and into the target sodium, that is 135. So this comes out to 32 milliequivalents. But then, as we know, we cannot give we cannot correct such a high suddenly at 32 milliequivalents. So hence, the cutoff, as Dr. Umali had also told and Dr. Shekhar has also told, that our cutoff is usually around 10 to 12 milliequivalents per day, not more than that. So hence, what we calculated was 0.6 into the body weight, that is around 13 into 10 milliequivalents. So it was coming around to 80 milliequivalents of sodium to be given. That was 160 mLs of 3% saline to be infused over the next 18 to 24 hours. A repeat sodium came as 124 after 6 hours. By that time, even the seizures has ablated. So we were happy with the response, and the repeat sodium repeated after say around 24 hours, around 128. So it did not go above 10 milliequivalent. So we were happy with the way the things were going. Further sodium readings normalized with time, and it was within the normal range. So further investigations were done to look for the cause of sudden hyponatremia. The serum osmolality that was sent was 240 milliosmoles per kg. That was pretty low. The urine sodium was very high. It was 150 milliequivalents. The urine osmolality was 289 milliosmoles. The urine output of the child was almost 4 mLs per kg per hour, almost in the polyuric range. Clinically, the child had some dehydration. The BUN was on the higher side, although the creatinine was normal. So almost like a pre-renal state. Hence, the diagnosis for us was cerebral salt wasting. So how do you differentiate cerebral salt wasting from SIADH? In cerebral salt wasting, basically the ANP goes up. That is the atrial natriuretic peptide. And you tend to lose a lot of water, free water, as well as the sodium in the urine. Hence, the blood urea in these children with cerebral salt wasting will be slightly on the higher side. The creatinine clearance will be low because the creatinine may be on the lower side, as compared to SIADH, where the blood urea may be near normal. The urine volume is increased in cerebral salt wasting. They're slightly on the polyuric side, as compared to SIADH, where the urine output will be much lesser. The body weight, the cerebral salt weighting, it is decreased because of the dehydration, as compared to SIADH, where it may be either near normal or slightly on the increased side because of volume retention. The BPs are slightly on the lower side in cerebral salt wasting as compared to SIADH. The CBP will be low. And then comes the urinary marker, that is the urine sodium. In SIADH, the urine sodium will be maybe slightly above 30 millimoles per liter. But as compared to cerebral salt wasting, which will be much, much, much higher, as we saw in our patient, and there will be a progressive increase, if you notice. So further, the course of the child remained stable in the ICU, weaned off the ventilator, extubated by around 4 days, and was shifted to oral warfarin and shifted to the ward. Coming to case number 2, it was a 2-year-old boy who came with history of fever, loose stools, and vomiting for a period of 3 days. The child was extremely thirsty. The urine output was normal as per the parents. There was no history of any altered sensorium or abnormal movements. Antenatal history was not significant. And the mother said in the past, the child had 2 similar history of dehydration episodes in the past, and that too requiring hospitalization. So here the odd part was, child is thirsty, looking dehydrated, but urine output is pretty normal. But this was what the mother said. On examination, the weight of the child for a 2-year-old was just 8 kgs, less than third centile, and the height being just 75 centimeters, which is what you expect for a 1-year-old child, again less than the third centile. The child was tachycardic, the BP was normal, the saturations were normal, the peripheral pulses were well felt, the capillary filling time was approximately 3 seconds, and the oral mucosa was dry, the skin turgor was poor, the eyes were sunken. The child had frontal bossing, pallor, systemic examination was normal. The initial investigation that came in showed that the hemoglobin was 8.1, the BUN creatinine was high, about 63 of BUN, and creatinine was 1.9, which is much higher for a 2-year-old child. The sodium, potassium, both were low, the sodium being 121 and the potassium 2.2. The calcium was low, the phosphorus was low, the alkaline phosphatase was high, magnesium was near normal, the pH was maybe slightly on the higher side, 7.47, and the bicarbs being 25. Again, an odd part, the child is dehydrated, bicarbs looks normal. The chloride was low, around 85. The urinary electrolytes that was sent off was the urine sodium was very high, around 80, and the potassium was 40. Now remember, this was sent at admission rather than that we have given some fluid challenge and then maybe did the electrolytes. The albumin was fine, urine protein was 1+, the stool examinations was normal. So final diagnosis was acute gastroenteritis with some dehydration with failure to thrive, with dyselectrolytemia and acute kidney injury. Dehydration was correction was given, IV fluids were continued, calcium potassium supplements were given. So what we found over the next couple of days was child started improving, the BUN creatinine normalized, the AKI had totally settled down, the sodium potassium basically hovered like near on the lower side of normalcy. The sodium did not go above, you can say 130. It was hovering between 128 to 131, potassium 2.9 to 3.2 with all the supports. Chloride was 90 to 98, and there was a good urine output, almost like 4.9 ml per kg per hour. So what we suspected at this time was maybe this child is having a diuretic phase of ATN, acute tubular necrosis. The urine output is high. That was the reason why a lot of losses are occurring. So we waited for a couple of days, but did not find much of improvement. The urine output continued to be on the higher side. Meanwhile, other investigations showed that the pH now is gone into alkalotic side. It was 7.54. The bicarbs had increased to 32. The urine sodium and potassium continued to be on the higher side, which may be slightly dubious because we are also giving a lot of supplements. Ultrasound of the kidneys showed normal sized kidneys with nephrocalcinosis, and again the 24-hour calcium being very high. Normal urinary calcium 24 hours is supposed to be less than 4 milligrams per kg per day, but in this case it is almost double. So here again a doubt was there that we already given calcium supplement because the serum calcium was low, whether that is causing the hypercalciuria or not. But since it is almost double the normalcy, so chances were there that the child may be having hypercalciuria from the background. Plus there was also medullary nephrocalcinosis noted on the ultrasound. So it looks like it's a hypercalciuric child. So now the current diagnosis was failure to thrive with polyuria and recurrent dehydration episodes in the past, with persistent dyselectrolytemia of sodium, potassium chloride, all being on the lower side, with metabolic alkalosis, hypercalciuria, nephrocalcinosis, and an increased urinary loss of the sodium, potassium, and chloride. So hence our diagnosis at this moment was now Bartter syndrome. And it was also confirmed by the genetic analysis done at a later days, and it was a type 2 Bartter syndrome with the ROMK mutation, which came as positive. Serum renin and aldosterone levels were also done, which was pretty high, and the child continued to have normal blood pressures. So this child on follow-up was like given indomethacin. The potassium chloride supplementation, what the potassium syrup was given, and the requirement of potassium in this child was almost as high as 5 milligrams per kg per day. The sodium chloride was given, 3% saline was given on the oral by mouth, and his requirement for sodium was as high as 7 milligrams per kg per day. So a take-home message here is, so kids where your electrolytes are not getting back to normal, having a high urine output, maybe you have two DDs in your mind. The first and foremost, maybe in case if the background of AKI is there, it may be a diuretic phase of AKI or ATN, which usually resolves within a couple of days, and you will find that there is an improvement in the sodium level, the potassium levels, slowly your supplementation reduces down, the polyuria phase comes down. So this is a diuretic phase of ATN. But on the other hand, if it continues like that, and the child on the other hand has metabolic alkalosis, then think about syndromes like Bartter syndrome. So how do we approach children with hyponatremia? So based on the serum osmolality. So if you have a normal serum osmolarity, so usually what we may think of is hyperlipidemia or hyperproteinemia, which is also called a pseudo hyponatremia like scenario. But usually in today's scenario, where majority of the labs, if they are using iron specific electrodes for measurement of sodium values, usually this pseudo hyponatremia may not be there. So labs which are not using iron specific electrodes, there because of the dilution part, you may get hyponatremia. So in case the child has high osmolarity, as the child may be already hyperglycemic as in DKS or receiving mannitol for maybe from CNS condition perspective, again you may get hyponatremia. So these two constitute the pseudo hyponatremia like scenarios. But on the other hand, if the osmolality is on the lower side, that is hyposmolar, this child is actually having true hyponatremia. So just a passing mention that in case of hyperglycemia, the sodium is decreased by 1.6 milliequivalents per liter for every 100 milligram % rise in glucose. So this is for your correction factors. So how do you approach such children is first confirm hyponatremia, it's pseudo or actual. In case it's an actual hyponatremia and it's a hypoosmolar state, assess the renal functions, whether it's a primary renal disease where the child is losing sodium in the urine. And in case it is there, treat the cause. In case the renal disease is not there, assess the volume status. If the child is edematous, then what you think of is a congestive cardiac failure, a cirrhosis, or scenarios like nephrotic syndrome where they have dilutional hyponatremia. In case the child is volume depleted, check for the urine sodium. If the urine sodium is less than 15, maybe the kidneys are conserving the sodium, then you think of scenarios like diarrhea, vomiting, burns, pancreatitis. On the other hand, if the kidneys are losing sodium and the urinary sodium is more than 15, then you think of diuretic abuse, salt losing nephropathies. On the other hand, if the child turns out to be normovolemic, assess the adrenal and the thyroid function. In case it is there, abnormalities are there, treat them. Otherwise, look for like, is there the kidneys are able to are you able to dilute the urine in response to a water load? Like when you give maybe a bolus of water or a free water, then either kidney are basically you can dilute the urine or not. So in case the child is able to dilute the urine and the osmolarity falls, what we are thinking is a psychogenic polydipsia. Okay, but in case that is not the scenario, then it is SIADH. So this is a small flow chart on how to go about in a child with hyponatremia. So what is the goal of the therapy? The goal of the therapy is raise the plasma sodium at a very safe rate and to replace the sodium deficit as well as correct the underlying etiology. So whenever a child comes to you with hyponatremia, look for the ECF volume depletion. If it is there, what you need is salt and water supplementation, like in scenarios like diarrhea. If there is a normal ECF volume like SIADH, what you need is just water restriction and things just fall on track. And on the other hand, if you have increased ECF volume, like cirrhosis, nephrotic syndrome, you are supposed to limit, you're not supposed to give salt because that is already in the normal side. Water restriction is the key. And at times, in resistant cases, you can give loop diuretics. So how rapidly should we correct the dysnatremia or the hyponatremia? So children who have chronic...
Dr. Kanav, sorry to interrupt, but in benefit of time for the other speaker, I would request you to please
Fine, sure. This last two slides. So how rapidly should we correct it? So in case it's chronic asymptomatic hyponatremia, you're supposed to go very slowly. Do not increase the sodium to above 10 to 12 milligrams per liter per day. And you can start at 0.5 to 1 milligrams per liter per hour. And whereas in acute symptomatic hyponatremia, so you can give a faster correction. You can give a bolus of 3% saline as well. And the correction can be double of what is there for chronic asymptomatic hyponatremia, that is 1 to 1.5 milligrams per liter per hour for the initial 3 to 4 hours, as we did in our first case. And subsequently, you are supposed to give at a lower rate. But try not to cross 10 to 12 milligrams per liter per day. So how does the brain adjust to the hyponatremia? So this is the last slide. So in scenarios like when the normal brain is there and the hyponatremic state picks in. So because of the low osmolality, the water gain is there in the brain. There's an edema that comes up. If this continues for some time, what happens is to adapt to it, the brain starts losing the sodium and the potassium and the chloride into the ECF, and the brain starts shrinking down, and so that the edema can be taken care of. If this state of hyponatremia continues for the next 2 to 3 days, then there is also loss of organic osmoles into the ECF, that is your glutamates and taurines. At this scenario, if you correct rapidly the sodium, usually osmotic demyelination occurs and the brain shrinks still further. But if you correct it properly, the brain returns back to the normal state. So what you are supposed to look at when you treat hyponatremia is features of central pontine myelinosis, that is the dysarthria, dysphagia, paraparesis, and on the late stage lethargy as well as coma. Usually occurs 2 to 6 days after correction. But remember, it is irreversible and has a poor prognosis. So better to avoid it rather than think of treating it. Thank you very much.
Thank you, Dr. Pranav.
I think we should let the other person present, and then we can, if we have time, we can have some comments after that.
Yeah, so I welcome Dr. Indira Jaikumar. She's a senior consultant in emergency medicine and critical care at Apollo Children's Hospital and Specialty Hospital. And I think most of us do know her, and I've heard her many times talking on electrolytes, and she is always interesting. Welcome, Indira.
It's 1 second. It's interesting now she's a senior consultant. I used to know her as a junior consultant. So she's grown.
Yeah, in more ways than one. Good evening, and thank you, Intensive Care Chapter of Mumbai, for this opportunity and for an academic treat by stalwarts yesterday and the previous 3 talks today. We manage so many diseases in the ICU that sodium disorders in comparison may seem, and sodium may seem just like an innocent bystander, but we can see now that we cannot underestimate this seemingly innocuous but treacherous electrolyte. It is often the first clue of something more sinister with the devastating consequences to very important organ, the brain, and as Dr. Uma Ali said, other organs as well, including the heart, and can contribute to mortality, and correcting it can be maddeningly frustrating for an intensivist. And as the previous speakers mentioned, it is very important to check in stubborn sodium disorders in ICU for balance of the fluid in and the fluid out, electrolyte-free water in the urine, and to remember that potassium administration can also change the sodium concentration based on Edelman equation. And as Dr. Shekhar has mentioned, slow correction is better than overcorrection. So I'm happy now to introduce to you all today Dr. Chidambaram, a very capable junior consultant at Apollo Children's Hospital. He will discuss hyponatremia case scenarios, and we eagerly look forward to the pearls of wisdom and expert comments from Dr. Shekhar and Dr. Uma Ali. Over to you, Dr. Chidambaram.
If you don't mind, Dr. Chidambaram, yes, go through the case scenarios, yes, but if you have, just tell us how you treated the patient rather than how you would treat the patient.
Yeah, that's what.
I'll just start scanning my screen. Before I begin the talk, I'm very happy and pleased to be presenting this case-based discussion on hyponatremia.
Cannot see your screen yet.
Chidambaram, your slides are not visible. Bhavik, can you please help him out?
So you will have to share your screen from your end. You'll just have to click on the share screen button and click on your presentation.
Yeah, I have clicked on the share screen button. Is it coming now?
Yeah,
it'll come.
On.
Okay, yes, good.
Yes.
Thank you. Before starting on the presentation, I would like to say that I'm very happy and pleased to be presenting this case-based discussion on hyponatremia among all the stalwarts in pediatric ICU. And a big thanks to Indra ma'am for teaching, training, and mentoring me and all our fellows during the past years. Thank you, ma'am. So over to the topic. So this hypernatremia and sodium is like canary miners. Canary is a small bird which will scare the miners and say, miners, you are in danger. This is because carbon monoxide poisoning, which can occur in coal mines, is easily detected by looking at the canary birds because they're affected first before humans. So coal miners will be looking intently at the birds. So similarly, intensivists will be looking intensely at the sodium to see what clue is going to give us to manage it further. We all talk about sodium, but it's essentially only about water. Sodium is just a barometer for the water content in the body. Before going on to the case-based presentation, just a small note on Edelman's equation, which is the father of all sodium equations. So according to this equation, the plasma sodium is directly proportional to the exchangeable sodium and the exchangeable potassium that is present, and inversely proportional to the total body water. So when there is a loss of total body water, it results in a sodium gain. So I would like to present a question-based approach for each case scenario. So first 3 questions will be based on etiology, and the next 3 questions will be based on how we will manage. So question number 1, what is the hypernatremia due to in each case? Is it a pure free water deficit? Is it a water deficit more than sodium deficit? Or is it an excess of sodium? If it is a water deficit, where is the water deficit occurring? Is it extra-renal losses or renal losses? And how is it being maintained? Is it because the patient is not having thirst, or is it because he is not able to take orally? So the next question will be, what is the excess sodium due to? Is it oral, or is it parenteral like 3% NS or too much of normal saline? Or is there a pathogenic reabsorption like it happens in primary hyperaldosteronism and Cushing's? And question number 4 is, what is the volume status of the child? From these questions, we can start finding out how to manage the patient. Is he hypovolemic, hypervolemic, or euvolemic? The next question will be, what is the fluid correction we are going to give? What is the rate and the amount? So that will depend on these answers, whether a shock is present or not. How high is the serum sodium value? Is it between 145 to 165, or is it more than 165? This is just an arbitrary cutoff to differentiate between too high and not so high. And whether the hypernatremia that is occurred is acute or chronic. Acute is less than 48 hours, chronic is more than 48 hours. The next will be, what is the type of loss, which will help us determine the choice of fluid, whether it's a pure water loss or it's a water and sodium loss. So if it's a pure water loss, then we can replace by free water like T5 or oral free water. If it's a water plus sodium loss, then initially isotonic hemolysis, followed by later hypotonic solutions like half NS and M/4. So now that we have answered all our questions, we need to have a goal and limit in our mind. So the goal is to reduce the serum sodium by 8 to 10 milliequivalents in 24 hours. This is by about 0.3 milliequivalents per liter per hour. This is especially important in a chronic hypernatremic situation. The limit is to avoid reducing it by more than 0.5, and it's very important to ensure that this limit is not exceeded. So as you can see, we can go slow and correct the goal. That is not a problem, but we shouldn't be too fast and exceed the limit. If we exceed the limit, when there is rapid correction of chronic hypernatremia, it leads to cerebral edema, which is a very important complication that can happen. The sodium content of various fluids was already described by our previous speakers, so I'm not going into the details. Dr. Uma Madam also told about most important thing with the sodium content of medications. This is also something that we should not forget. So what is the guiding principles in treatment of hypernatremia? So first is what will guide us to decide on the rate of fluid, whether there's a presence of shock. So if there's a presence of shock, we give isotonic bolus only, not hypotonic. How high is the sodium value? The more higher it is, the more severe dehydration is there. We have to continue isotonic fluids to avoid a rapid drop in sodium, while we still continue to correct the intravascular dehydration.
Dr. Chidambaram?
Yes, sir?
Can you please go to your cases?
Okay. So skipping to my cases, the first case is an 8-month-old male infant who is having history of fever, loose stools, weight loss, whose posturing, who is irritable, and whose urine output is reduced. On examination, the child is irritable. There is a bulging anterior fontanelle. There's intermittent posturing, and there's a dovey skin. The vitals show that the heart rate is high, the tachycardia, and blood pressure is also on the lower side. And the mother reveals a history of improper mixing of ORS and 200 ml of water. The investigations reveal serum sodium to be very high, 165, and urea to be high 60, which is pointing towards intravascular dehydration. The weight of the last vaccine visit was 10 kgs. So the probable diagnosis is a hyponatremic dehydration in shock with altered sensorium, probably due to CNS bleeding. So our questions which will help us manage what is hyponatremia due to? It is excess of sodium as well as water deficit more than sodium deficit. Volume status, the child is in shock. What is the water deficit due to? It is due to extra renal use.
Please continue. There is somebody's mic which is not muted.
Yeah, okay. And also its water deficit is continuing to be ongoingly present because the child is able to not take orally. And the excess sodium here is the inappropriate ORS given by the mother. So what will help us determine the rate of fluid collection? Shock is present, the sodium value is more than 165. We do not know the duration, so it's safe to assume chronic. And the type of loss is water plus sodium loss. So I would like to touch upon a few formulas which would help us to calculate the initial fluid choice and the initial rate. One is the Adrog-Medias formula, which is based on Edelman's equation. So this formula states that the change in serum sodium per 1 liter of any administered fluid is equal to the infused sodium plus potassium contained in the fluid minus the current serum sodium of the patient divided by the total body water plus 1. As Shekhar sir truly said, we assume for pediatric age groups 0.6 into body weight as total body water. One more formula where we can just know what is the free water deficit is, where 4 ml per kg of free water, say 10 kg child is there, 40 ml free water. If the sodium is more than 170, we'll take it as 3 ml per kg. It will drop the serum sodium by 1. But this is one more formula. I'll go into it when we have the case. So what is most important thing to remember is there is no magic formula. These are all just to start the initial fluids. After that, it is just titration. So rate of fluid administration for this particular child, the child had a shock. So initially 20 ml per kg, 200 ml NS bolus was given. Assuming that it's an infant who is dehydrated in shock, so 15% dehydration correction. So the deficit will be 1500 ml, which we would want to correct over 2 days. The total fluid requirement is the deficit plus maintenance. So maintenance will be 1 liter into 2 days, which will be 2 liters. So the total fluid is 3.5 liters, and we have to subtract the bolus. So we need 3.3 liters over 48 hours, which is roughly around 70 ml per hour. So just as a small exercise, how do we use the formula? So when serum sodium is 165, and for 1 liter of each fluid, suppose we take n by 2 for example, that can, and for all we'll assume that we're adding 20 milliequivalents of potassium in the fluid because anyways it's a child with loose stools. So 77 milliequivalents of sodium is present in the fluid along with 20 milliequivalents of potassium minus current serum sodium, which is 165, divided by the total body water, which is 0.6 into weight 10 plus 1. So that gives us that if we use n by 2 1 liter, the sodium will drop by 9 milliequivalents. So similarly for n by 4, it will drop by 15 milliequivalents. Whereas for NS, it would raise by 1.5 milliequivalents. For 3.3 liters of the above fluid, since we wanted to give 3.3 liters as per our calculations before, if we use n by 2, there will be a 29 milliequivalents drop. And if we use n by 4, there will be a 49 milliequivalents drop. We want maximum of only 8 to 10 per day, which means a maximum of 20 in 2 days. So the closest fluid that we have here is n by 2. So how do we decide how much to give now? So as I told you, the goal is 16 to 20 milliequivalents per liter drop in 2 days. The formulas are just a guide. They can underestimate the fall in sodium. Hence, it is better to start with 2/3 of the calculated fluid rate. So instead of 70, we start with 50 ml per hour. And we have to remember to replace the ongoing losses. So then we'll do a 4th hourly sodium intake output and titrate accordingly. Every 4 hours, if serum sodium drops by around 1.5 milliequivalents, that means in a day 1.5 into 6, so 9 milliequivalents we lose. That means we are on the right track. If the drop is more than expected, then we'll reduce the fluid administration rate or we'll change it to a less hypotonic fluid. As I told, all formulas are only for initial fluid calculations. This is one more complicated formula where we use fluid deficit, free water deficit, and solute fluid deficit. I'm not going into the details. So essentially, if a child is hypovolemic and hypernatremic, if you know the obvious cause, whether it's vomiting or loose stools or whether there is a diuretic, then we do not do urinary sodium. Or if you do not know, urinary sodium more than 20 means as a renal loss. If it's less than 10 means as an extra renal loss. So then we'll decide upon first initial giving saline and then going on to a hypotonic solution. So now switching on to the next case. This is a 6-year-old child, 20 kg with 40% burns. The child was taken to a local hospital. 500 ml IV fluids was given. Dressing was done. The child was brought to here 2 hours after the incident. Our primary survey, all the vitals were normal. Fluid collection was started by Parkland formula and 2.7 liters RL was given over the remaining day. Urine output slowly picked up. Serum sodium was normal and HP was also normal. On day 2, the child became tachycardic, heart rate worsened to 140, blood pressures remained stable on 90/60, the peripheries were cold, CFT was prolonged, urine output also started to drop. For pain, the child was on morphine infusion and the burn wounds looked clean. On our lab parameters, serum sodium had gone up to 160 and HB has gone up to 14, which is also an important marker of intravascular dehydration. And the capillary blood glucose is also high, 280. So what do we think right now? So there is a hypernatremia. The probable reason is hypovolemia. There are 2 contributing factors. One is an insensible water loss excessively happening in burns, and other is an osmotic diuresis due to high blood glucose. So again, a quick run through of our questions. Hypernatremia is due to excess of sodium. It is due to water deficit more than sodium deficit, but in this case, more of insensible water loss. What is the volume status? This child is in hypovolemia shock. The water deficit is due to an extra renal loss to the skin. The excess of, and also renal losses because there's osmotic diuresis happening. And the excess of sodium is due to parenteral. About 2.7 liters fluid was given. Determinants of fluid correction, the child is in shock. The sodium value is 160. And this is an acute problem. So in acute hypernatremia, the correction can be faster. 1 to 2 milliequivalents per liter till 145 is reached. Burns is a case where there's large insensible free water losses to the skin. But still we should avoid overzealous correction because it will result in burn edema. So to avoid overzealous correction, we can titrate the urine output of 1 ml per kg per hour. And hypernatremia is not just a number to treat in burns. It delays wound healing and it contributes to as much as 15 to 30% of mortality. So continuing our case, the child is in compensated shock. 10 ml per kg NS bolus was given over 1 hour. And the water deficit can be calculated by using this formula, which is total body water into 1 minus 140 by serum sodium. By that, the water deficit comes to be 1.5 liters. The maintenance for 1 day for this child is 1.44 liters. So the total fluid, when we minus the bolus given, we get approximately 2750 ml. So by using Adrog-Media's formula, we'll see what happens when we use D5 and what happens when we use half NS. When we use half NS, the expected drop is 6 milliequivalents in 24 hours. When we use D5, the expected drop is 12 milliequivalents in 24 hours. So in this scenario, we can choose to use both. Feeding is very, very important in burns. Early enteric feeding is very important for wound healing. So we can start 1.2 liters as 50 ml feeds, 50 ml per hour feeds with water. The feeds will contain roughly about less than half sodium, and the water will be like a free water. And 1.5 liters as 60 ml per hour of half NS. This is just a trial and error method. We can then monitor 4th hourly sodium, monitor the urine output, and titrate accordingly. One more important thing to remember in a burns child is if there is refractory hypernatremia and excessive edema and you're not able to give more fluids, then it most likely is time to perform some form of dialysis. So now going on to what the previous case also was a hypovolemia. Now going on to our next scenario. This is a 3-year-old child, 10 kgs, craniopharyngioma, who was operated. Pre-op, all the electrolytes, thyroid, cortisol was all optimized. At 6 hours, there's a call from recovery room after surgery is over. The child is tachycardic, the child is hypotensive, rest of the vitals are normal. Pulses are feeble, peripheries are cold, the child is having tachypnea. The serum sodium is normal, urine output is a touch on the lower side. So what are the possibilities here? This child is probably having either a bleed or a secondary adrenal insufficiency. So we have to check the fluids, losses, and HB. If everything is normal, then post a craniopharyngioma surgery, adrenal insufficiency is common, so we have to increase the dose of steroids. The child continued to be in ICU, shock has resolved. Strict intake output chart is being maintained. The intake is 40 ml per hour. The urine output is 120 ml, and then next hour is 140 ml. It's going on increasing, and the child's sensorium is becoming more and more irritable and drowsy. And this is how the child's urine is looking like. Very dilute and large amounts of urine. So now this child is having polyuria. Polyuria can either be central diabetes insipidus or cerebral salt wasting or fluids in the perioperative period. All of them will have a lot of urine volume. The most important differentiating factor will be the serum sodium. The serum sodium will be high in the central DI. It will be low in cerebral salt wasting. Whereas in fluids in the perioperative period can be mostly normal. So we continue with the case. The serum sodium was found to be 170. Urine specific gravity is 1.001 and urine osmolarity is 70 millimoles per liter. So it's a dilute urine and high serum sodium. Together it adds to diabetes insipidus. Usually in craniopharyngioma it is immediately post-op. Not necessarily always, but in this case there could have been a reason for the delay. The delay is there's a cortisol deficiency. It usually masks the diabetes insipidus because cortisol is needed for free water excretion. Only if cortisol is replaced, diabetes insipidus becomes overt. A similar scenario we see in SAIDH because we cannot do SAIDH until and unless cortisol deficiency is excluded. So again, the diagnostic criteria: plasma osmolality more than 300, urine osmolality less than 300, and the child is polyuric. And always we have to have normal blood sugars. So going back to our simple questions, what is the hypernatremia due to? It is a free water deficit. Volume stated, the child is euvolemic. Water deficit is due to renal losses. What fluid to choose? Here, a routine post-op isotonic IV fluids can worsen the hypernatremia because it's an absolute free water loss. So either we have to give hypotonic like 0.45 or free water. So the child is now having a serum sodium of 170 milliequivalents. What is our choice of fluid? In view of severe hypernatremia, the goal is to reduce a little slowly by 3.3 milliequivalents per liter. So pure free water may drop the sodium too rapidly. Hence, initial few hours you can start with half ms. Rate of fluid. Unlike other dehydration scenarios, once vasopressin is given, the urine output will drop immediately. So the replacement cannot be fixed. It has to be tailored to the hourly urine output. So we can split the fluids into two. One will be maintenance fluid. Maintenance fluid will be 40 ml per hour of half DNS because the child is 10 kg. The replacement fluid will be urine output minus intake, which is 140 minus 100, which is 100 ml per hour. So similarly, it has to be calculated for every hour. So then serum sodium has to be tracked 3 to 4 hourly. If sodium is not changing, then better to immediately switch over to free water, either oral or D5. So vasopressin is an important drug in DI. There are two forms. One is an aqueous vasopressin, one is a nasal vasopressin. Aqueous vasopressin is very preferred in the acute setting because it has a duration of action of only 5 to 10 minutes. It's potent and it's an IV infusion. Nasal desmopressin, it is 20 times less potent. It is very erratic and it has a long duration of action of 8 to 12 hours. So it's not preferred in an unstable child in the ICU. One important thing, practical component to remember in vasopressin is, if you all know, vasopressin comes as 1 ml is equal to 20 IU. Our dosing is only 0.5 milliequivalents per kg per hour. So how do we dilute it? We take 0.25 ml, which will be 5 units, and add it to 500 ml of NS. That 500 ml of NS now contains 5 units or 5000 milliunits. Sorry, which means there's 10 milliunits in 1 ml. 25 ml of the above solution, we take and add it again to 25 ml NS. So now 250 milliunits is present in 50 ml, which means 5 milliunits in 1 ml. Now it's easy to give. Then nothing but we're double diluting the vasopressin. So vasopressin was started at 2 ml per hour, which is equal to 1 milliunits per kg per hour, targeting the urine output to drop to 1 to 2 ml per kg per hour. Previously, the urine output was as high as 10 ml per kg per hour. But surprisingly, we find that 2 hours later, the urine output is still 120 and it looks very dilute. But the sugars are normal and serum sodium is much higher, 176, and the child's sensorium is worsening. So what are the possibilities? We have to recheck everything. What volume of fluid we gave, what is the tonicity of fluid, and most importantly, what is the vasopressin dilution. So vasopressin was wrongly diluted. 0.1 ml was taken instead of 0.25 ml. Hence, it is reloaded again. So after reloading has happened, but still the serum sodium is high. So how can we change the fluid orders? Maintenance fluid still remain the same. Replacement volume is still the same concept, intake minus output, so 80 ml. But the replacement fluid type, it is better to switch over to D5. So now after correcting the vasopressin, the urine output dropped to 40 ml. The serum sodium remained at 1. When serum sodium improved to 170. At this situation, would we like to change anything in fluid and vasopressin orders, and how long should we continue the IV vasopressin? So vasopressin should be continued at the same dose till hypernatremia is less than 160 because it is working at the same dose, and as the child sensorium should also improve when we can switch over to nasal or oral desmopressin. And D5 volume should be reduced to match the urine output. As urine output drops, immediately the D5 volume should also be reduced. Now, if serum sodium drops too rapidly, we can change the fluid either to half NS or reduce the vasopressin, provided the urine output is less than or equal to 0.5 ml per kg per hour. If the serum sodium is still increasing, then we can increase the D5 rate or increase the vasopressin dose. So as we can see here, vasopressin causes this dilute large amounts of urine to become concentrated small amounts of urine. Case continued. On day 2, the child's sensorium is normal. Serum sodium is 145. We are very happy. But suddenly on day 3, the child again becomes drowsy and the serum sodium drops to 125. And the urine output is at 1 ml per kg per hour. So what are the current possibilities? So the child could have gone into SAIDH. It could be a vasopressin overdose, or it could be excess fluids, or a combination of any one of them. So in a hyponatremia child, in a child with DI, how do we assess the scenario? So we have to see whether the child is getting any thiazide diuretics. If so, we have to stop. Is it based on any anticonvulsants like carbamazepine and lamotrigine? It can trigger an SAIDH. So we have to stop them and readjust the desmopressin dose also. Is there a cortisol deficiency? If so, we have to adjust the hydrocortisone dose. Then we can withdraw the desmopressin. After withdrawing the desmopressin, if urine output improves, becomes polyuric, and serum sodium also improves, then it was a desmopressin over treatment. We need to adjust the dose. But if this doesn't happen, there is no improvement after withdrawal of desmopressin, then we are facing either SIADH or a cerebral salt wasting or a mineralocorticoid deficiency. So this is the triphasic response that is described in most of the patients having craniopharyngioma post-op. So initial phase is lot of urine output, diabetes insipidus. The next phase is a SIADH phase where urine output is low. And the next phase is a DI phase again when the urine output is high. So initial 1 or 2 days, the urine volume is high, there is DI. Then for the next 3 to 7 days, there is SIADH. Then again, it goes into a phase of permanent DI. Some children may pass directly into permanent DI without going through a SIADH phase. So once we know that the child is in SIADH, what should we do? We should maintain a strict intake output and restrict fluids. So overall management of the triphasic response. First phase, as we already described, hypotonic fluids and vasopressin. Second phase also, as we described now, is SIADH, restrict fluids, stop vasopressin, and give isotonic fluids. If the child is asymptomatic hyponatremia, we have to be careful and avoid diuretics as well as avoid 3%, as permanent DI can set in any time, and giving a 3% will overshoot the sodium value. And third, and the most important, in permanent DI, you can switch over slowly to tablet desmopressin and nasal desmopressin. So similarly, in our case also, on post-op day 5, the child's sensorium is normal. There is polyuria intermittently. Sodium is now 150. We have to assess thirst and intake. If both are present well, we can send them home on oral desmopressin tablets. The only important thing to remember to tell parents is there should be a 2-hour breakthrough polyuria period before next dose is given to prevent water intoxication. So now going on to a next case where there's a similar free water.
Lakshmi, do we have time, or should we open up for any questions of the cases?
We can stop here with the cases and we can discuss them here. If there are questions from the
So if there are any questions from those listening, could you please put forward your questions?
Lakshmi, you can read the questions.
There are no questions which I can see in YouTube or in Zoom.
Okay. Shekhar sir, you are muted.
So I think all 3 cases were excellent.
Yeah.
And very well presented and discussed. So in spite of little shortage of time, I think it was well discussed and well treated.
I do have a comment about a patient that presents with dehydration as well as hypernatremia. The correction speed. I think most people will correct see, there are 3 components. One is replacement of the dehydration. The second is maintenance fluids. And the third one is correction of the sodium concentration. In my opinion, it is only the correction of the sodium concentration that needs to happen over 48 to 72 hours. But often what we do is we do all 3 of them over 48 to 72 hours. That is incorrect. If the patient was isonatremic, would you choose to correct their their fluid deficit over 48 hours? You would not. You try to correct their fluid deficit as quickly as possible. So I think the fluid deficit calculation should be corrected if they are not in shock over the first 24 hours, the first 50% in the first 8 hours, and the other 50% in the next 16 hours. The maintenance will be the same. It's the same rate throughout the day. It is only the water correction or sodium correction, either hyponatremia or hypernatremia. That is the only correction that has to be done over 24, 48, 72 hours, whatever you plan to do. That is the only comment I would make. That's the way I manage patients. I know that there is a variation in practice, but it seems scientifically makes more sense to me to focus on the correction of the sodium over 48 hours and not correction of the entire thing over 48 hours. I don't know what Dr. Umali thinks about that.
Generally in hypernatremia, I correct the deficit over in equal installments rather than first 8 hours and then 16 hours. Unless there's any pressing need to do. Very rarely you find hypernatremia with shock.
Yeah,
I agree. Think the volume is preserved. Yeah. So I don't have the same urgency as I have in a hyponatremia, isonatremic patient. And I also know the urine output in severe hypernatremia is going to take time because there's so much ADH. The ADH is responding to volume as well as hypertonicity. So I'm not alarmed by the lack of urine output in 4-6 hours, which I would be in any other dehydration. So I do correct it a little more slowly because I feel that gives more stability because there are too many interactions which bring the sodium down, but I do understand what you're trying to say. But in practice, what happens is that because of the high prevalent ADH levels in gastroenteritis, dehydration, and other extrarenal, sometimes you find a very rapid fall. As you correct dehydration, the ADH stimulus goes. And then you find, there is because ADH is more responsive to volume. It's less sensitive a stimulus, but it's a more potent stimulus. So if you have like a 7% volume loss, you will get ADH irrespective of what is your osmolality.
I totally accept your your approach. The other additional point I would like to make is that you cannot expect urine output to improve until you have at least replaced 50% of the deficit. So if you're choosing to replace it slowly, don't expect, like Dr. Umali said, expect the urine output to improve until you have at least corrected 50% of the deficit. Because urine output is going to be dependent on blood volume. And since the blood volume replacement is slower, you have to wait till that replacement is done up to a certain point, and then you will see a urine output improve. So there are a lot of people, they will see that the urine output has not improved and start giving boluses of 10 ml per kilo, 10 ml per kilo. That is incorrect.
I totally agree with that. Both boluses as well as furosemide are a big no when you're dealing with hypernatremia. So you may choose to follow it, if you wish to correct dehydration a little faster, in preference to giving boluses and Lasix.
Do we have a few minutes? I wanted to show some slides.
So I would just say there was an important discussion going in the chat box between you and Dr. Karnav. I think it's a very important misnomer about hyperchloremia and AKI. Do you want to highlight that? Is it that hyperchloremia causes AKI, or is it hyperchloremia and the strong ion balance maintained, or hyperchloremia with hyponatremia and hypoacidosis, low bicarb does not, while pure hyperchloremia might? So, you want to just touch base for everybody to get that.
Sure. I think before I do that, let me show you a couple of slides that will actually illustrate the point. Okay. Let me share the screen. So we worry about damage to the brain when a patient presents with hypernatremia, but we don't seem to worry too much about a patient who already has an injured brain, where we are using hypertonic or osmotic treatments to treat their intracranial hypertension. So I want to show you some slides that show that osmotic therapy is not necessarily without problems. So these are all not clinical studies, but these are all bench studies. Mannitol at clinical concentrations activates multiple signaling pathways and induces apoptosis in endothelial cells. And they compared hyperosmolar mannitol, sodium chloride, as well as urea, and they produce the same kind of effect, meaning that the effect is due to osmolarity and not due to the particular molecule in question. It's the osmolality or osmolarity of the solution that actually produces this problem. The same way, hypertonic saline worsens infract volume after transient focal ischemia in rats. So you can see that the focal ischemia in rats increases after treatment with the hypertonic saline. There's also myocardial dysfunction when you have high sodium chloride induced apoptosis of the cells. So PMNs in blood also undergo apoptosis when they are exposed to hypertonic solutions. So the answer to the discussion that Kanav and I had, it is my opinion that it is osmotic changes in the kidneys and other places that actually causes the tissue injury, not an isolated ion. It is a total osmolar stress that the cells see that causes the injury. It is not isolated to sodium or chloride, or that's my understanding of reading this literature, that it's more the osmolarity of the cell, what happens in the tubules versus the cell versus the blood. That difference in osmolarity stresses the cells. And at some point in time, the cells can undergo apoptosis or actually have injury. That's my understanding. That is what, even though statistically in many clinical studies, you may see an association between strong ion difference and mortality, or strong ion difference and AKI, chloride levels and AKI, sodium levels and AKI. I don't think they are actually causal links. They're only association in a statistical way. What I think is happening are osmotic stresses.
Madam, you wanted to share some point on that?
Look, which you were asking about chloride, I think the final answer is still not there. There are many animal studies which do show that chloride's excess has a vasoconstrictive action on the renal vessels and may cause an AKI.
Yeah.
But I think each situation is a little different. Like with yesterday's discussion, that we never look at it with what is the sodium status with that chloride, what is the acid base. So I think we perhaps don't have the right answer yet. Maybe chloride is a molecule to watch, but every case may be a little different from the other. And it's like comparing oranges and apples that we make the errors, is what I feel.
Excellent.
Sometimes we are not actually comparing, at least there the comparison are between two fruits. Sometimes it may be oranges and some other thing.
Sheikh sir.
Yeah.
Okay. I think it's time to conclude. It's already 11:03, midnight over here, Shekhar sir. And before I conclude, I must bring in our president, who have been always he works more, speaks less. So definitely I would like to bring him, Dr. Parmanand. Under his leadership, we have started this initiative. And I think it has been, very success. Past 2 days, we have seen a great focused discussion and interaction and our participation from the delegates. So over to Parmanand sir for 2 minutes.
I thank Sheikh for those kind words. It was such a great learning for last 2 days. Nice to see Shekhar sir interacting with us and giving such an insight about defluid electrolytes and sodium. And so it was a great learning, and I hope everybody enjoyed these 2 days. And we will continue. And the great support of our team like Amish, Lakshmi, Minaz, and all the EB members of the Mumbai IAP. Definitely we'll have such a programs. We are interacting with getting a good speakers, so we all learn and enjoy. Thanks again, Shekhar sir, Kanav, Indra Kumar ma'am, and Umali madam for being there and helped us to learn many new things. Thanks once again.
Thank you for inviting me.
Yeah, thank you, Parmanand and team, and bye, Shekhar. Good night from my side.
Thank you.
Thank you, Indra. Thank you, Kanu. Thank you,
Bye,
madam.
ma'am.
Thank you,
Thank you, sir.
everybody.
Thank you.
Bye, Shekhar.
Thank you, Shekhar.
Thank you, madam.
Bye,
Thank you.
Lakshmi.
Bye. Bye,
Thank you.
madam.
Bye. Good night. Take care.
Bye,
Bye.
Parmanand.
Bye, ma'am. Indira, ma'am.
Thank you. Thanks a lot.
Thank you,
Bye,
Indira.
Indra. See you.
Actually, Ravish was asking about you. Ravish and Maina from Australia.
Ah,
They were my colleagues at Wadia. They were
right.
junior to me, and they were asking about you.
How
So
are-
they wanted your number. So I had to share your number to Ravish.
Please do share.
Yeah, definitely.
Nice.
Thanks.
Thanks.
Kanu,
Bye.
you did
Dr.
well.
Kanav.
Indira, madam, both the cases were phenomenal. Both the, I mean, our Kanu and Indira did excellent. Very well. Thanks a lot.
Thank you. Thank you. Thank you for this opportunity.
Thank you. We'll be again meeting after a couple of months.
Bye bye. Good night.
Thank you.
Bye.
Bye.
Good night.
Thank you, dear. Thank you all. Good night. Good night. Bhavik, thank you. Just a minute. If we are limit, okay.
Yes, sir.
Yeah, remove these couple of people. We'll have a couple of words. Chidambaram, Nitin, Hemant, other. Okay. Let other people remove, and then we'll have a couple of words. Indra, can Indra? Hello.
Yes.
No, sorry. Just we are done. Bhavik.
Yeah, I'll
Yeah,
leave.
please.
Yeah.
You can leave. Chidambaram, Nitin. A small meeting we'll have. Yeah. Chidambaram, you did well. Yeah.
Thank you, sir.
Yeah. Nagaram that day. Okay. I think there are a couple of people we should meet. We'll have to meet. What do you think, Amir Bhai? Their meeting still been there. People.
Chidambaram, can you leave, please? Thank you.
Oh, thank you.
There are many. Bhavi, can you take?
Just take control and let them go, no?
Yeah. Bhavi.
Yeah.
for 2
whom
minutes,
else
no?
should I?
No. Wait for 2 minutes.
Yeah.
And stop the YouTube.
I have.
Thank you.